You can start. Okay. Assalamu alaikum. Our research about the outcome of the operative correction of the thoracolumbar junction fracture in the patient. وفي هذا. Outcome of the operative correction of the thoracolumbar junction fracture in the patient admitted at 48 Model Hospital during 2090 to 2021 Sana'a, Yemen. The thoracolumbar junction is the most common area of the injury to the spinal columnar. A wide variety in the injury pattern and clinical presentation is equal in this region. And because of the spinal cord, as they know, is ended in this level. The thoracolumbar junction fracture, almost all neurosurgeon is contact from the T11 to the L1. This is a sample for the thoracolumbar junction fracture. Our objective to know the distribution of the thoracolumbar junction spinal fracture according to the age, gender, mechanism of the injury, type of the fracture, and neurological deficit. And also the second objective for our research to know the outcome of the operative correction of the thoracolumbar junction spinal fracture according to the kyphotic angle and vertebral body height by posterior spinal fixation. The methodology and materials of our study. The database taken from the study design, descriptive, prospective study, and the data collection sample. 45 civilian patients come to the 48 Model Hospital with traumatic thoracolumbar spinal fracture. All of them underwent of the surgical treatment during the period 2 years from 2019 to 2021. My database collecting from the patient underwent the surgical spinal fixation by questionnaire. The surgical treatment is doing and early follow-up and evaluation by X-ray and CT scan. The study analysis or the result analysis by SBSS design. The parameter, the questionnaire parameter, age category to the 5 group. Below 50 years and group from the 60 to the 30 years, 31 to 45 years, and 46 years and to 16. Gender, male to male, and mechanism of the injury. 4 categories is RTA, fall down, gunshot, and sport. But neglected the sport because it's neglected in our country. Level of the vertebral fracture, thoracic from T1 to T10, thoracolumbar junction from T11 to L1, and lumbar from L2 to L5. Type of the fracture, we use a dense classification, associated neurological deficit, and preoperative body height and kyphotic curve, and postoperative body height and kyphotic curve. Inclusion criteria. All the patient indication for surgical intervention based on the mechanical unstable pattern of the spinal fracture and neurological status of the patient. The timing of the surgical, all our patients done within 3 weeks of trauma. Exclusion criteria, any documented deformity of the spine, patient with the coagulopathy and anticoagulated therapy, non-traumatic thoracolumbar junction fracture, secondary to the tumor, osteoporosis, and infection, minor thoracic lumbar fracture, and delay presentation more than 3 weeks. Solidar patient, because my hospital is the military hospital. Pre-operative workup, details history and examination, details laboratory and radiology investigation, medical anesthesia fitness, preparation for operative, prepare the patient by tell the patient about the management plan and the outcome from the plan, take the consent from the patient or from his or her relative, blood and antibiotic also prepared. Surgical treatment, as you know about posterior fixation, simple segment, short segment by 4 screw or 6 screw. Similar manner for any posterior spinal fixation, prone position of the patient under general anesthesia and midline incision according to the level of the fixation, and after that supraperiosteal dissection of the spinous process and transverse process and lamina and facet joint by monopolar and bipolar, and preserve the facet joint at the level above and below of the fracture site. Pedicle screw instrumentation by, as you tell before, 4 screw or 6 screw above and lower, guiding by imaging CR. In the case we require decompression, إذا في معنا كان compression about the spinal cord, doing decompression and laminectomy as standard fashion. Follow up and evaluation. Patient post-operative keep in the bed rest. Initially do early rehabilitation and movement of the patient in the bed or by using of the belt, because for preserved doing complications such as DVT or ulcer decubitus. Early post-operative check X-ray and CT scan done for correction the placement of the screw insertion. The outcome by X-ray and CT scan to the lateral view to kyphotic angle and anterior vertebral body height. Our result and discussion. First one, distribution according to the age. The most common age in our study is between the 15 to the 30 years old, and the next one between 46 years to the 60 years. Our study is similar to the other study done by Adrian, was the mean age is 30.4, and McAfee was the mean age is 32.2, and Krombinger was the mean age is 34.6. Our study is exclude of the patient over the 60 years because the patient is bone density poor and complain from the osteoporosis and decrease in the mental state, that all of them is increase the accidentally fall down and again recurrent fracture. Distribution according to the gender or to the sex. Our study result, male is more common than female by twice, approximated 69% male and 31% female. Our study is similar to the Sweden study and study in the Japanese. The most result for man more than female because The men are mainly engaged in the activity outside of the house in the heavy worker, and women rarely drive car and never drive motorcycle in our country. Distribution of our 45 civilian patient according to the mechanism injury. The most mechanism of the injury is road traffic accidents. Our result is 73.3. Our study is similar to the study done in the Sweden, and there is a study in Japanese against my result because the most common mechanism where accidentally fall down by 85%. In our study, most common of the RTA due to lack of the strict traffic safety regulation in Yemen. Most cars are not equipped with airbags. The people have no motivation to use safety belt. Also, sport in our country is neglected. Distribution of the thoracolumbar junction fracture according to the level. The most common level for that infection, the fracture is thoracolumbar from T11 to L1, about 53.3%. You can see here fracture in the L1 and L312. Our study is similar to the Krombinger study. The most frequent injury is thoracolumbar junction, 48%. Lumbar region, 34%, and thoracic region, 80%. The increased effect of the thoracolumbar junction fracture in the trauma can be due to the thoracolumbar junction area between relative fixed thoracic spine was protected by the thoracic rib cage to the fairly mobile unprotected lumbar spine. The transitional from the normal thoracic kyphotic to the lumbar lordosis. The location of the facet joint coronally in the thoracic and sagittally in the lumbar, resulting is more susceptibility to injury in this area. Type of the thoracolumbar fracture according to the dense fracture. The most common fracture is compressed fracture by near to be 49%. And the second one, breast fracture, 28.8%. And after that, fracture with dislocation, 50.5%, and flexion destruction. This is the classification of the dense classification. As we know about anterior and middle and posterior columnar.
2 minutes.
Okay. Our result is similar to the dense with review patient. The most common fracture is compressed fracture by 47.8%. Neurological deficiency, most patient at this level fracture is normal without neurological deficiency, about 51.1, and partial and completed neurological deficit, about 48%. Our study, there is similar study by Philip Young and Leverning, is less than our study. The high result in our study may be due to wrong pre-hospital management of the spinal cord injury as mobilization and transport, delay in the diagnosis and management inside the hospital, absence of the well-qualified team and center. This is the most important result you can discuss with us is the presence of the kyphotic deformity in the patient. The most presented is a kyphotic deformity between 1 to 20 degree, about 21 patients, and post-operative decrease to that 10 patients. The main kyphotic degree is 20.4 degree, and pre-operative. Post-operative is 4.6. The differential between the pre-operative and post-operative about 50.8 degree. 77.5 corrected in the kyphotic angle. Our study is similar to the study done in the Korea and Germany. The last one, pre-operative and immediately post-operative, mean loss of the anterior vertebral body height. Pre-operative is 54%, post-operative 10%. The main difference is 42.8% corrected in the height of the left vertebra. Okay. Conclusion, the most age of the thoracolumbar fracture between 62 to 30 years, the male is more, 2 times more female to have this fracture, commonly caused by RTA, and most common affected site was thoracolumbar junction. The most common type of the fracture were compressed fracture, and about half patients have partial or complete neurological deficit. We also, this most important conclusion, the early operative treatment with transpedical screw is effective, safe, simple, provides stable rehabilitative segments construction, can correct the kyphotic angle and vertebral height to acceptable degree, prevented a possibility of occurrence of the secondary spine deformity, also allow to a quick recovery and early rehabilitation and return to the work in the operative patient. Our recommendation in the thoracolumbar fracture fixation indicated can be to do early, before 3 weeks, to prevent it from the healing. If healing is occur, you cannot thus benefit from the fixation. We recommended patient with the suspected spinal cord injury, careful with the embolization, transplantation, and evaluation by radiological and physical examination. Traffic safety regulation need to be adopted in our country. Thank you for your attention.
شكرا دكتور. أي أسئلة؟
Any question?
Any question? Sorry, there is no time. Dr. Idris. Dr. Idris Nu'man, high grade glioma management and
have limited time, so please start quickly. Welcome everybody for second day of 4th Yemeni Neurosurgical Conference. And I will thank the administration of this conference for giving me a chance to give my lecture about high-grade gliomas. This is beautiful islands, Socotra, in Yemen. Most of our professors know about this island. My introductory slide, which I show you here, for 3 patients. The one in the left side is ring enhancing lesion in the and flare segment in the lower row. And the other 2 patients on the right, they have mildly enhanced or no enhancement at all. And these biopsies for these 3 patients comes to be glioblastoma multiforme or high-grade glioma. So my home message for today is, what you see is not always what you get. The second home message is, everybody knows about the classification of high-grade glioma. Finally, they both grade 3 and grade 4 as high-grade glioma. The new thing is that addition of IDH mutation. They found that in IDH mutations, there is improvement in the survival and progression-free survival rates. Means if the patient having IDH mutations, he has good prognosis. So this study was done at 2010 by Hartman and others, and it was clearly showing that patients with high-grade with GBM with IDH mutations, they have overall survival as well as progression-free survival rates are high. And here IDH mutation comparing to IDH wild type. So I did study some cases in SDH hospital. It was about non-enhancing, the rate of non-enhancing high-grade gliomas. We identify about 231 surgically treated gliomas with tissue diagnosis from August 2011 to January 2022. And we found that 24% was non-enhancing lesions. And among these non-enhancing lesions were 28% were high-grade gliomas. We compare our study to study was done in German in Heidelberg series, and they found that non-enhancing lesions were equally distributed between grade 2, grade 3, and grade 4 WHO grading. So regarding surgical management of high-grade gliomas, it is a balance between maximized extent of resection and preservation of function. The prognostic factors for high-grade gliomas or any glioma include age, pre-op functional status, and molecular markers. As we said, IDH mutant types, they have good prognosis comparing to IDH wild type. And we can add also minimal residual disease. And to achieve minimal residual disease, we need good tools, all the tools and equipments to maximize the extension of resection. Just have a look at these MRIs. You can see here the ring enhancing lesion on the MRI one with contrast compared to the flare MRI. So the question is, which area we should resect? Should we resect the ring enhancing lesion only, or should go beyond the ring enhancing lesion which appear in the flare MRI? Here, there is a study was done by Stomer 2008 and shows that the gross total resection adds nearly 5 months in survival rate. And another study was done in San Francisco by Sinai and shows there is stepwise improvement in survival even in the 95% or 100% extent of resection. And this was taken from paper at 2013 and summarized the issue. And if we take biopsy only with best supportive care, there is chance of increased survival by 3 months. And if we do biopsy and we add radio or chemotherapy, we can add 8 months in the survival.
5
And
months.
if we do partial resection, we can add 11 months. But if we do complete resection, then we can go beyond 1.5 years. And here everybody knows about this paper done by STOP trials, which shows that temozolomide adds 2.5 months in the survival rate. So the controversies in high-grade glioma management includes supramarginal resection, resection of recurrent GBM, or glioblastoma in the elder patients or in the deep-seated patients. About supramarginal resection, we were talking about supramarginal resection that there is some study shows gross total resection plus more than 50% of flare adds 20 months in the survival. And here there is some patients shows like the one in the left side, right frontal lobectomy, the one in the right side, right temporal lobectomy, and all out progression-free survival and increase after lobectomy with no any neurocognitive functional disturbance. And this is about recurrence. There is some studies. Director trial was done in Germany and shows improved survival and quality of life after gross total resection. As well as taking patient for surgery in recurrent GBM will give us another tissue to study for detection or any change in molecular or genetics, which may need another type of treatment. So resection of recurrent GBM prolongs survival and augments target therapies. About elderly, there is maximized resection in elder people is helpful as long as it's safely achievable. So here there is some study which shows that surgery done in patients more than 65 years and another surgery done in patients more than 70 years. And all of these studies shows increased survival rate by near 5 to 6 months. And there is another study comparing biopsy or partial resection comparing to gross total resection and shows that gross total resection is more helpful than biopsy. Thank you.
Thank you, Dr. Idris. Good presentation. Anyone have a question? We have time for 1 or 2 questions. Let's see the chat, if there's a question in the chat. Looks like there is no any questions. Thank you, Dr. Idris. Thank you very much. Now we have Professor Dr. Hugo Perez from Mexico City. He's a well-known neurosurgeon and neuroanatomist, and he will give us now his lecture. Victor, can you hear me?
Yes, thank you so much.
Thank you for joining us, Professor. It's an honor for us.
Thank you, thank you. Let me share my screen. Okay.
Hola, Victor.
Hello, John. How are you?
Bienvenidos.
Thank you for this honored invitation to be here with all of you. I think the screen is complete.
Sí, sí, está bien ahora. Sí.
Thank you so much. Okay, thank you very much to Dr. Ahmed and all of you for this honored invitation. I'm going to speak about vascular anatomy of the lumbosacral spinal cord segment. I want to show you this video about injection of the spinal cord veins. I think is very nice because in here we can see how the veins are filled with this silicone in color blue. So with this technique, when I inject the lumbar spinal vein, I can feel almost the lumbar and middle thoracic segment. So let me show you again, because I'm going to speak later about the surgical implications about these spine veins. So let's go for the other slide. Once we have injected the posterior radicular artery in the posterior aspect of the spinal cord, we have these beautiful pictures about the vasculature of the spinal cord. It was Albert Adamkiewicz in Poland in these years when he started to inject these arteries in the spinal cord. This is a drawing obtained from an original article by Adamkiewicz, published in 1881-1882. Now with the technique we are using here in Mexico, we can get these beautiful pictures about the vascularity of the brain and also the spinal cord. Spinal cords were extracted via a longitudinal midline posterior incision from the occiput to the sacrum. Anatomic dissection was performed until reaching the vertebral lamina. Laminectomies were performed from C1 to L5. The spinal nerves were cut with care so as not to lesion the dura, as you can see in here in this picture. Then we injected the spinal arteries with this silicone in color red. This is the Adamkiewicz artery. We inject this with moderate pressure and close inspection to avoid contrast extravasation. The injection is continued until latex filled distal small caliber arterial vessels, including the posterior spinal arteries. The great anterior radiculomedullary artery, also known as Adamkiewicz artery, is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. Here we have the aspect of this Adamkiewicz artery. A left-sided vessel was present in 45 specimens, and a right-sided was present in 5 specimens. This is in the right side, this Adamkiewicz artery. Here we have another view of this beautiful Adamkiewicz artery. Here we have the lumbosacral segment and the Adamkiewicz artery ending in 3 arteries. In this picture, we can see the trifurcation with the 2 posterior spinal arteries. This is one of that, another one, and this is an artery that goes to the filum terminalis. Although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important radiculomedullary artery is the arteria radicularis magna, otherwise known as the artery of Adamkiewicz. This artery arises in the thoracolumbar region between T8 and L2 in 75% of patients and has a diameter of almost 1 millimeter. This is a lateral aspect of this artery, Adamkiewicz artery, the conus medullaris. Here we have the conus medullaris, and this is the trifurcation of this artery. One artery goes to the filum terminal, and this is the posterior spinal artery. Here we have an aspect of the Adamkiewicz artery, and in the upper slide, we have a thoracic artery. As you can see, the diameter of the thoracic artery is with almost 200 or 300 microns. And this is almost 1 millimeter and 1.2 millimeters. The preoperative localization of this artery is very important in the surgical transthoracic spine procedures. The anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. This is the highest level of Adamkiewicz artery in our study, about 50 spinal cords. This Adamkiewicz artery arises in the T3 in the left side. So here you can see the cervical segment. This is C1, C2, 3, 4, 5, 6, 7, 8, and then the thoracic nerves 1, 2, and 3. So here is the origin of this Adamkiewicz artery. This artery has a long trajectory in the anterior aspect of the spinal cord. So here we have a close view in this picture. Adamkiewicz artery arising from left L2 was the lowest level. Here you can see the lowest level in our study in this artery, Adamkiewicz artery. Let me show you in the next slide a retraction of these spinal nerves in order to see this Adamkiewicz artery, and then its branches. One of them, the posterior spinal artery, as you can see in here. The artery of Adamkiewicz side and level of origin. We have these segments, T3, only one, and L2, two arteries of Adamkiewicz. The most common, the most common location of this artery was T9, 13 in the left side and 1 in the right side. Here we have two arteries of Adamkiewicz, an accessory radicular artery in here. A close view of this artery. The understanding the basic vascular anatomy of the spinal cord is of utmost importance for imaging, interpretation, and endovascular and surgical management of spinal cord vascular malformations. Advances in diagnostic and therapeutic interventions have led to a need for more detailed and specific understanding of the microvasculature of the spinal cord, in particular attention to the anatomic variations of the smaller caliber circulatory supply to the spinal cord allows tailored management of a specific patient. This is posterior aspect of the spinal cord. In here you can see the posterior spinal arteries, one in each side of this spinal cord, and the vein, the great posterior spinal vein. And in this video, I want to show you a dissection
aspect of the spinal cord, filum terminale, caudecina, the conus medullaris. We can see the veins of the posterior aspect of the spinal cord. This is a small vein. This is the aspect, posterior aspect of spinal cord.
Look at this. I am doing dissection of this posterior aspect of this spinal cord, and then we localize the great posterior radiculomedullary artery. This is a very important artery that is giving rise to the arterial supply to the posterior spinal cord in the lumbosacral segment. Let me continue the video.
Here we have the posterior radiculomedullaris artery, the magna posterior radiculomedullary artery.
The anatomy of the great posterior radiculomedullary artery. The existence of this artery has attracted little attention and has been a matter of debate. Various authors postulate such a vessel: Gilliland, 1958, Lasortes, Romanes, Jellinger. Others do not mention it or even deny its existence, like these authors. According to Jellinger, a large posterior radicular artery is seen caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels, diameter 350 and 500 microns. Its site is more caudal than that of the anterior radicularis magna artery. So there is no doubt about its existence of this great posterior radiculomedullary artery, as you can see in this posterior aspect in this spinal cord. In the anterior aspect, we can see the Adamkiewicz artery here, and this is the great posterior radiculomedullary artery. Let me show you this video in order to follow the direction of this artery.
Posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve and goes to the posterolateral aspect of this spinal cord. then returns to the posterior aspect between L3 and L4 nerves. Great posterior radiculomedullary artery.
This artery in the spinal cord specimens was injected with colored latex until the small caliber arterial vessels were filled and the great posterior radiculomedullary artery was identified. The course, diameter, and location of great posterior radiculomedullary artery were documented. This is another video.
Here we have the posterior spinal artery that is coming from the Adamkiewicz artery. This is the posterolateral aspect of this spinal cord. Here we have the posterior spinal artery.
This makes an anastomosis, a really nice anastomosis between the great posterior radiculomedullary artery and the posterior spinal artery. These arteries joined and supply the posterior spinal cord in a very good manner.
This artery is going to make a beautiful anastomosis with the great posterior radiculomedullary artery. Let me show you in this video a very significant feature. So in this side of this spinal cord, the left side, we don't have an anastomosis between the posterior spinal cord with the Adamkiewicz artery at the conus medullaris.
In this spinal cord, there was not a GPRA. Instead, there were several radicular arteries, as you can see in here, in these radicular arteries. A variable number of radicular arteries originating from segmental arteries or homologous vessels make arterial contributions as lateral feeders along the course of the spine. These radicular arteries are of small but differing calibers. Most of these radicular arteries supply nerve roots, the dura, the pial plexus. Only a few of these radicular arteries specifically provide arterial supply to the collateral network of vessels supplying the spinal cord. These vessels are specifically termed radiculomedullary arteries. A great posterior radiculomedullary artery was identified in 72% of spinal cord specimens. This total includes specimens in which unilateral and bilateral GPRAs were found, as well as a single case in which 3 GPRAs were evident. In 26% of these specimens, a unilateral left side GPRA was present. A unilateral right side was present in 22% of the specimens. In 22% of the specimens, bilateral GPRA were present. Like in this case, we have 2 great posterior radiculomedullary arteries, each in one side of this spinal cord. One specimen demonstrated 3 right-sided GPRAs. And the distribution of GPRA based on side and spinal level. As you can see, it was more frequent in T12, 9 in the left side and 9 in the right side, T12. There is no doubt about its existence of the great posterior radiculomedullary artery, although this artery 50 years ago was denied for some researchers, investigators. GPRA is conclusively present in most 72% individuals. Understanding this intricate anatomy and inspirations is critical for addressing vascular malformation of the spinal cord. A better understanding of the spinal cord circulation will lead to reduce risk of surgical and endovascular spinal and aortic procedures. Let me show you these videos about the veins of the posterior spinal cord. And in here, I can demonstrate that in some specimens, we have too many veins for too many veins, like in this, here, in this, here. And in other spinal cords, we have less venous, draining veins in here, like in this case. Great spinal anterior vein. The diameter in this case was 0.8 millimeters, and the average is 0.46 to 1.3 millimeters. Let me show you some pictures about this. Some anatomic variations. And this posterior spinal vein was 1.80 millimeters. This is a venous plexus in the spinal cord. I could not identify a fistula in this case, but let me show you the characteristic way of a fistula. This is dissection. This is dissection of the posterior aspect of the arachnoid. As you can see, this arachnoid is more adherent in the posterior spinal cord than in the anterior spinal cord, as you can see in this video. In the anterior aspect, the dissection is easier than in the posterior spinal cord. Very easy to dissect the arachnoid in the anterior aspect. So let me show you this picture about a spinal dural arteriovenous fistula. This text was taken from Clinical Presentation and Prognostic Factors of Spinal Dural Arteriovenous Fistulas by Lancino and other collaborators in Neurosurgical Focus. Progressive neurological damage due to a vascular disorder of the spine has been recognized for more than 50 years. The advent of selective spinal catheter angiography has allowed the identification of the most common type of spinal cord vascular malformation, the spinal dural arteriovenous fistula, or type 1 spinal vascular malformation. These lesions are defined by abnormal connections between a radicular feeding artery and the coronal venous plexus of the spine without an intervening capillary bed. The actual fistula site is at the dural sleeve of the nerve root. In this case, in here, it was the fistula. Let me show you the posterior slide. These pictures, surgical pictures, were taken also from this excellent article written by Giuseppe Lancino. And in this picture, we can see the tortuous veins of the coronal plexus. And in this side was the fistula in the anatomic specimens. This article was written in the American Journal of Neuroradiology about 3 years ago. So thank you very much for your attention. This is the last slide showing the lateral aspect of this spinal cord. And in here we have a very good anastomosis between the posterior and anterior aspect. Look, the really nice anastomosis are arterial and venous anastomosis in this spinal cord. So,
And very nice specimens.
thank
We
you
have-
so much.
Adnan, we want to ask you.
Dr. Victor,
Thank you,
about
thank you.
information in the cervical cord, where is the most common location for it?
The most common what?
Venous malformation.
Oh, the dural type 1, the dural fistula arteriovenous. The dural arteriovenous fistula is the most common. I have found in my specimens, I have found 2 dural arteriovenous fistula. Like the one I showed you in a picture.
You find only 2 cases in cervical or where? In which segment of the spine?
Excuse me?
In which segment of the spine?
It was in the lumbosacral segment.
Okay, thank you, Doctor.
Doctor, I have another question for you, please. In case if I have grade 3 arteriovenous malformation in the anterior part of the cervical spine, what do you suggest for management in these cases?
The surgical management, I think, is much better and very simple. The only one you have to do is to coagulate, localize. First of all, you need to localize the site of the fistula. Once you have localized this connection, only coagulate, and that's all. It's very simple.
Thank you very much, Doctor. It's a great pleasure and honor for us to have you with us in our conference. Thank you very much.
Thank you. It's an honor for me. Thank you so much.
Thank you. Now we'll have Professor Atul Goel, the king of craniocervical junction, and he'll have many theories and many interesting concepts in the craniocervical junction. But now he will be talking about approaching the skull base. Dr. Atul Goel. Dr. Goel.
Yes, yes, just a minute, just a minute. I'm just,
The king is preparing his train.
can you see my slide, John?
Yes.
Okay, so I'm absolutely honored and absolutely delighted to talk to very handsome neurosurgeons of Yemen. And I must say that Yemen has been very advanced during these COVID times in webinars. And I know that I have talked to Yemenis neurosurgeons several occasions, and many of you have heard me not once, but many times. And I convey my best regards, best wishes to all young and old Yemen neurosurgeons, and wish that Yemenis neurosurgery progress to an extent that proudly you all can say we are the best. There is no excuse in neurosurgery. We can never say we are poor country, we are having war, we have this, we are You know, we should be proud of our work. You have several patients and you work hard and produce the best results that is possible. There are no excuses. Our patients do not want excuses from the doctors. So my topic today will be dura and skull-based tumors. I know many of you have heard me because I have given these kind of lectures on several occasions in my life, particularly in skull-based for at least 35 years. Dura and skull-based tumors. Needless to say that if we want to do any kind of advanced neurosurgery, we have to be very, very good in anatomy. And we heard Victor from Mexico, what beautiful dissection, what beautiful injections, and absolutely fascinating. You have to be good in anatomy. You have to go to the cadaver lab, no question about it. So these are my books, which I had published in 1996. You can imagine, so many years ago. And this book was reprinted 3 times during that time. And we had talked of complex neurosurgery, clival neurosurgery, cavernous sinus surgery, and things like that. And many of you have heard about my philosophical concepts. Nobody knew exactly what is cavernous sinus, whether it has some function, whether it has some role to play. I do not want to go details of these speculations and philosophical considerations, but I'm putting some articles for you to read because they are beautiful speculations about the function of cavernous sinus, about its role in vision, about its role in eye movements. And cavernous sinus indeed is it supports the eyeball, it supports the vision, it supports life. So cavernous sinus has immense functions, its relationship to the carotid artery, its relationship to the nerves of the extraocular movements, its relationship with the pituitary gland, its relationship with the nasopharynx are all functionally absolutely important. Just to tell you a few words about the functionality and nasopharynx. Nasopharynx is like air conditioner of the body. When the air goes inside the nasopharynx, it may be hot and cold, but the extensive vascularity of the mucosa makes this air conditioner, gives information to the cavernous sinus. Carotid artery gives information to the cavernous sinus about internal temperature. Cavernous sinus then gives information to pituitary gland, and pituitary gland then regulates the body. Cavernous sinus has great function, great role, and I wish and I want you to read some of my articles on the subject. I want to start my presentation from what I got from Arabic legacy, Alum al-Dimag. This sentence I got from Arabic literature, and Osama al-Mafti liked it very much. I talked about it 35 years ago. And since then, in all my lectures on cavernous sinus, I introduced this statement. It means that meninges are the mother of brain. Meninges are the mother of brain. Tumors also respect the dura. Tumors also have absolute great respect for the dura. So surgeon has to be respectful of the dura during surgery. And the philosophy of dura I will like to discuss. So dura is durable, and dura is a very compact, makes the brain isolated from rest of the world. You know, the skull may be weak, skull may be broken, but the dural tear is a dural transgression by the tumor or by the infection is quite rare situation. The dura covers the brain, and when the nerves and artery exit the brain, the dura is along the nerves and arteries. This sentence, the dura goes along the nerves and artery. The nerves do not penetrate, it does not go in a hole of dura. The dura goes along with the nerves. So these are my papers. You see, during that time, in about 25, 30 years ago, nobody used to do very few people used to do cavernous sinus surgery, and the understanding of anatomy anatomy was not there. MRI had just been introduced in late 1980s. So nobody exactly knew cavernous sinus location, the relationship of tumor with the carotid artery, relationship with the dura, relationship with the cranial nerves were not understood at that time. And some of these articles were very popular 25, 30 years ago. So this is relationship of the tumor with the carotid artery. You see, MRI introduced relationship with carotid artery. Before that, nobody knew because CT scan was not able to give exact relationship. Some tumors encased the carotid, some tumors displaced the carotid, some tumors squeezed the carotid. So on the basis of how the tumor has a relationship with the carotid artery, this was my article in 1998. And I think quite an article during those days. So my most important thing is in my life that I worked in a public hospital, I worked in a free hospital, I worked in very busy hospital, operating, always continuous operating, many tumors. You know, I became head of department at the age of 36 years. I was head of department for 24 years. And I became a neurosurgeon at the age of 27 years. So I had some opportunities to do good, beautiful neurosurgery early in my career. In 1993, this was one of my most beautiful collections in 1993. So many years, 27, 28 years ago, I did this tumor. 1995, I did this quite an horrendous tumor, as you can imagine, going in orbit, going in cavernous sinus. Small tumor residue in 1995. I had given radiation at that time. Normally, I don't like to give any kind of radiation for residual meningioma. So this was the case I did. You can see the radicality. So in my life of neurosurgery, I never thought that I cannot do good neurosurgery from India. I never thought that we are a poor country. I never thought that we will not be able to do the best neurosurgery of the world. I never thought that we are inferior to anybody. So I just did because I had opportunities to do these kind of beautiful cases, and I continued to do them throughout my life. Extradural approach, cavernous sinus is extradural entity. It is not intradural, it is extradural. The whole cavernous sinus is like superior sagittal sinus inside the dura. So for the first time in the literature, we introduced extradural approach to cavernous sinus tumors. You see, Vinko Dollens, my good, absolute, fantastic teacher or master of cavernous sinus, has talked about intracavernous aneurysm. But this was in 1997, the first article on intracavernous sinus tumor. Cavernous sinus is extradural. The tumors inside the cavernous sinus are extradural. So I will talk about it. This was the tumor, the most vascular tumor in neurosurgery, most difficult tumor. And this is cavernous hemangioma of the cavernous sinus. This is primarily intracavernous. It remains within the dura. It respects the mother dura mater. Dura mater means mother. It respects the dura mother. It remains within the confines of cavernous sinus, goes towards intercavernous sinus, goes towards orbit, goes towards Meckel cave. And this was the first case in the literature where preoperative and postoperative images were published in a journal. This tumor, I don't think there was any publication before this where pre-op and post-op image were shown. So these tumors, no matter how big they become, they're benign. They remain confined to the dura. They respect the dura, mother dura, go towards the intercavernous sinus, Meckel's cave, orbit, dura remain. Most important thing is the cranial nerves are located on the wall of the tumor. They are not inside the tumor. Even the sixth nerve is displaced on the inferior dome of the tumor. So those relationships, if you want to operate on this vascular, heavily vascular tumor, you have to know, you see, these tumors can be quite dangerous. You can have bleeding issues. They remain, you see, angiographically occult, but they are bleed and bleed and bleed. So this was the first article in the literature where it mentioned that these tumors can be removed extradurally. And subsequently, many other authors have produced have liked this extradural approach to these tumors. More recently, I produced my series of 45 cases, my personal series, which is the largest series in the world on this tumor. So these are rare tumors. So this is intracavernous hemangioma. I'll quickly like to show you a video of this if possible. You see transgastrian, and this is extradural, working within the cranial nerve, within the gastrian ganglion, and you see how it is bleeding. And you have to be very, very careful. You have to, first identify the sixth nerve. You have to work over the carotid artery loop, because the sixth nerve is lateral to the internal carotid artery. And then you have to hurriedly, you see, the most important thing in neurosurgery is to learn the art of breaking the tumor, learn the art of demolishing the tumor, learn the art of capturing the tumor, and not just, coagulation. Coagulation is not the real way of removing the tumor. I don't like to coagulate inside the tumor, and these kind of vascular tumors you cannot coagulate. And if you spend your day, this is live, this is not unedited tape, this is not editing. I remove this tumor in 5 minutes. You see, this is the inferolateral trunk of the carotid artery, which is the main supply to these tumors. Sometimes McConnell's capsular artery, sometimes meningohypophyseal artery can be the supply to these tumors. Sometimes even the middle meningeal artery can be a supply to these tumors. Once you get to the tumor, this supply, you see, you can have a relatively avascular field, and then you can work within the cavernous sinus. These are difficult tumors. These are, these are benign tumors. Once you are able to remove, you can cure these tumors. Once you have removed the tumor, there will be venous bleeding like you saw just now. You work over the, you see, not lateral to the carotid artery, because you can damage the sixth nerve. You have to identify the sixth nerve early in the operation and then radically remove. You must remember that any cranial nerve deficit is possible. I'm not saying it is not possible, but if it is there, it is quite a devastating deficit of extraocular movement disturbance. Many of these patients come with extraocular movement disturbance, but I will recommend that these tumors are operable, and you must not ignore or neglect these tumors. So this is preoperative and postoperative. As I mentioned to you, I have done 45 cases, and now I have got few more cases, about 50 cases of cavernous hemangiomas, preoperative and postoperative. Here is the video, another one. I don't want to show you too much, but you see, just see, this is extradural exposure. And now this is V1, V2. Then I will, this is a little bit oldish video. Then I work in the Parkinson's triangle. After trying here and there, you see the whole thing is red. And if you are going to show me these tumors with complete bloodless field, I will not believe that, because this tumor, you have to learn to operate in a bloody field. If you want to operate majority of difficult problems, if you want to operate on simpler tumors, of course, that is another thing. But if you want to operate on pituitary meningioma, you just cannot go on, attack the tumor, attack in a very controlled fashion, and you can produce beautiful results. You have to, just overpower the tumor, and then you can have internal carotid artery inside the cavernous sinus. Sixth nerve has to be saved quickly and early in the operation. Beautiful operation, fantastic. And you see, you can give new life to the patient. You see, third nerve, no third nerve. And sixth nerve, no sixth nerve. So you can improve the cranial nerves, and there is only way. You cannot give radiation, and you cannot give gamma knife and all those things. Sometimes there can be a flow-related aneurysm, and you have to clip. This was the first case in the literature, and there are many cases. Now I want to quickly talk about pituitary tumors. Pituitary tumor is our life in neurosurgery. We love and live in neurosurgery operating on pituitary. You can give vision, you can give function, you operate on pituitary to understand pituitary tumors. I have got several articles on this subject. I wish you can read. Many of these tumors can become large. Many of these tumors can become huge. Many of these tumors can become absolutely giants, but they are benign. And if you understand this tumor, let me show you how these tumors extend. When they grow, it takes the diaphragm dura upwards. This concept was not there in the literature 25 years ago. The concept was a diaphragm celli has a hole and the tumor comes up in a subarachnoid space. For the first time in the literature, we said that the diaphragm celli is elevated by the tumor. And this completely revolutionized pituitary tumor surgery. This small little concept. You see, the dura is elevated. Dura mother, this benign tumor respects the dura mother. It respects the dura here. There will be thin bone, thin dura, but dura will be there. So this concept is absolutely important. You see this nubbin, there is dura around this nubbin. This nubbin, if you do not have the concept that the dura will cover this tumor, you just cannot resect this tumor. And if you have the concept that the dura is covering the diaphragm, covering here, you can come from the sella and remove the tumor, learn the art of breaking the tumor, demolishing the tumor. No need for coagulation in pituitary tumors, and respect the mother, respect the dura. You see, this is dura covering. This is not in the brainstem. If you do not have this concept, you can never remove this tumor. But if you have this concept that this is dura, you can easily remove this tumor and give a wonderful post-operative result. Second thing is it goes into cavernous sinus quite frequently. Dura of the cavernous sinus covers the tumor. Dura covers the tumor. So the whole tumor is within the dura, within the loving hands of the mother. And you have to know and understand this. Carotid artery can be encased by this tumor. You see, this is dura, dura, dura. So this concept of dura was not there 25, 30 years. I have given several lectures on this subject over the years, that dura can be stretched of diaphragm, dura can be stretched of cavernous sinus, but transgression of dura is quite uncommon. You see, this is grade 2 when the tumor goes in the cavernous sinus. See this slide carefully. The dura elevates the roof of cavernous sinus. Dura, you see the tumor. There is dura here, dura here. So the whole tumor is intradural. This tumor is intradural, you see. And that anatomical understanding, in my estimation, is absolutely crucial. You see how the dura of the cavernous sinus is elevated. This concept was not there, and probably still not there with many neurosurgeons. And my Yemeni neurosurgeon, you please try to understand this beautiful intradural location of cavernous sinus of pituitary tumor, elevation of roof, elevation of diaphragm, elevation of roof of the cavernous sinus. The whole thing looks, absolutely difficult, but it is respecting the mother dura. Rarely the tumor goes beyond the dura and encases the arteries. When the tumor goes beyond the dura, I consider it malignant. When the child stops respecting the mother, it is a malignant child or a absolutely terrorist child. So that mother respect is absolutely important. And this was my classification. The diaphragm can be elevated even when it goes to the skull. The diaphragm is intact. When the tumor goes inside the cavernous sinus, the dura is intact. This is grade 2. The roof of the cavernous sinus is elevated. This is grade 3. When the diaphragm is transgressed, arteries are encased, that is grade 4. So this is my classification. And I think this diaphragm celli introduction of concept was revolutionized pituitary tumor surgery. So open the sella dura, learn the art of breaking the tumor. This tumor you can remove in 15 minutes. If you remove it in more than half an hour, you do not know pituitary tumor surgery. I removed this in 1997, and this dura, this uterus, which is the strongest muscle of the body, has the power to push the baby down. Similarly, this dura and this pregnant baby, you just make an incision, the baby will come out and this dura will push the tumor. And in quick time, if you go on coagulating in this tumor, you will never be able to remove. Learn the art of breaking this tumor, and you give new vision to the patient in the immediate post-operative period. A magic will happen to him, a magic that will give you such beautiful pleasure. He will say, doctor, my vision has come back. You see, with subfrontal extension, the whole world was doing transcranial operation, but you just open the belly, remove the tumor, and you can remove this tumor. I removed in 5 minutes. Possible. Learn the art of breaking the tumor. Don't have to remove the planum spinoidal or tuberculum celli. Just remove the cellular wall, break the tumor, and learn how to deliver the baby. Don't use forceps like you use for pregnant child, but you use your suction, you use your beautiful instruments. You see this tumor, I operated 21 years ago, this tumor from the nose, and this patient is still beautifully alive and fantastically active. These are benign tumors. Learn the anatomy of diaphragm, learn the anatomy of location, learn the tumors, go on operating, and you can create magic. 22, 23 years ago, I removed just anterior wall of the sella. I removed this tumor. You see, like doing PR examination, you go and remove the tumor from behind. How you remove many of these tumors are soft and suckable, and you do it. They are not like meningiomas or bony tumors. Tumors in the cavernous sinus can be removed beautifully. They are soft tumors. Break the tumor, don't coagulate, don't use sharp instruments in the cavernous sinus, and you can do a beautiful job. When the tumor elevates the roof of cavernous sinus, they are more aggressive form of tumor, but you can go into the cavernous sinus and go to the roof of the cavernous sinus if you know that the dura is there. When the tumor goes beyond the diaphragm celli, these tumors don't fiddle around too much. These tumors are aggressive malignancies, and do not be too aggressive with these tumors. Now I go to another beautiful chapter of dura in my history of neurosurgery. You see trigeminal neurinoma. In 2003, I wrote this article with 73 cases. Now my experience is more than 300 cases with trigeminal neurinoma. These are of 3 types. In this article, for the first time, I wrote that you can improve the function of trigeminal nerve. This as a series. You can improve the function. I also wrote for the first time that these tumors arise in the region of Meckel's cave and then go for front or behind. And you see the tumor can be, these tumors in the middle fossa are interdural within the dura, and the trigeminal nerve is displaced on the dome of the tumor. This concept, if you have, you can remove. If you do not have, you cannot remove trigeminal neurinoma. In 1995, I removed trigeminal neurinoma without craniotomy, just widening the foramen ovale, identifying trigeminal neurinoma on clinical grounds, identifying on radiological grounds, working within the dura, and infratemporal fossa interdural approach. This tumor I removed infratemporal without craniotomy in 1995. Another beautiful tumor I removed in 1994. The tumor going in the posterior fossa from trigeminal neurinoma, of course. And I did just widening the infratemporal fossa bone, widening the Meckel's cave. So it is understanding of the dura is absolutely important and critical. Of course, now I do subtemporal craniotomy to remove this trigeminal. I don't do infratemporal fossa. Trigeminal neurinoma are the most beautiful tumors. Initially in my article, I wrote that this tumor in this posterior fossa can be like subarachnoid, but now I say many of these tumors have a dural cover, particularly multi-compartmental tumors, and work within the tumor, learn the art of breaking this tumor. 1991, I used to do 2-stage surgery. First remove the larger part and then use the smaller part in different exposures. In 1991, similarly, in 1992, I first removed this posterior fossa, then the middle fossa. But now, of course, for large tumors, I do extended basal craniotomy. I used to do in 1996, included mastoidectomy in the exposure for the first time in the literature. But now I don't include mastoidectomy. My exposures are very small. This exposure, splitting of the temporal muscle and going, exposing for tumors which are large in the posterior fossa. You have to go subtemporal, you may go intradural, and you have to remove. As I mentioned, I have got an experience of more than 300 cases, which is by far the largest experience in the world in this subject of trigeminal neurinoma, and I'm happy about it. Most important is break the tumor, learn the art of demolishing the tumor. Even when there is a nubbin like this, it is within the dura. Break the tumor, respect the mother. And you see, these are soft tumor. You can see necrosis in the tumor. Some tumors can be firm. Some tumors can be very firm. They erode the anterior clinoid process. They erode the Peters bone. There is no need to drill any bone. You have to just break into the tumor. When the tumor goes extracranial, this was my experience when I say in 2010, even the extracranial part is within the dura, and you remain within the dural confines and work within the dura, and you can, the carotid artery in the infratemporal fossa, the nerves in the infratemporal fossa are displaced by the tumor and not encased by the tumor. So that concept is very critical, and you can remove this part which is going in the infratemporal fossa by the side of the foramen rotundum, by the side of teeth, in the by V1, by doing a smallish craniotomy. So that is the thing. Even when there is a recurrence of trigeminal neurinoma, the tumor remains within the dura. Now I want to talk of third nerve tumor. These can be difficult and dangerous tumor. You see, you don't know what is happening with this tumor. But these third nerve tumor presenting with third nerve palsy, third nerve schwannomas are interdural. They arise with, like, in the oculomotor system, and when they become big, they are interdural. You work within the dura, and you can save the third nerve function after surgery or improve the third nerve function. That understanding of the dura is absolutely critical when you're going to operate on third nerve neurinoma. You see, there is a dural cover around the tumor. You identify, you break the tumor not by coagulation, but by your whatever instrument you have to do. If you go on coagulating, you will never be able to save the third nerve. So that art of breaking the tumor has to be learned by going on operating multiple tumors daily, all the time. If you are in tumors, you know, you can save the third cranial nerve. So sixth cranial nerve, I am still working on the dural relationship, but this is one tumor where you have to, you know, this is the schwannoma, which are rare sixth nerve tumor. Similarly, I want to show you seventh nerve tumor. Seventh nerve tumor arises in the region of geniculate ganglion, like acoustic nerve arises in the internal auditory meatus. This one arises in the near the geniculate ganglion and goes in front and behind. It remains within the dura. So this interdural strategy, if you identify the course of the seventh nerve, break into the tumor without going near the dura, you can save the seventh nerve and probably improve the function. And you can make this tumor difficult otherwise. You see, difficult. Carotid artery is displaced by the tumor, by the dura. And if you have that understanding, this difficult tumor can be operated in 20 minutes. Make a small craniotomy here and just start removing the tumor, and you can have a beautiful post-operative outcome. Similarly, my recent article on lower cranial nerve schwannomas, interdural surgical strategy. You see, these tumors are located in the region of the jugular bulb. They remain within the dura. Even when they go outside the confines of the skull, they remain within the dura. If they go inside, majority, I'm not saying all the time, they remain within the dura. If you work within the dura without violating the dura, respect the mother dura, you can improve the cranial nerve function. In this article, if you read in World Neurosurgery, I have mentioned that majority of my patients have improved in the lower cranial nerve function, which has never been reported in the literature. You see this tumor, you have to do mastectomy, you have to get into the, expose the tumor widely here, and then take a transverse incision into the dura and work within the dura. You see the whole dura, you can remove the tumor within the dural confines. And this you can make the most dangerous tumor of our subject into a relatively simpler subject. C2 neurinoma. C2 ganglion is behind the atlantoaxial joint. C2 neurinoma is the largest ganglion of the spine, like Gasserian ganglion is the largest ganglion of the cranium. C2 neurinoma has a very similar concept of extension like trigeminal neurinoma. This is C2 neurinoma. You see, this is interdural. This part, the intraspinal, we thought that it is intradural. Like this part, we thought in trigeminal neurinoma is intradural. But now I think that this part is interdural in majority of situations. Now we think that this part is also interdural in majority of location. In 2008, my concept was this part is intradural. In 2018, my concept is that this part is interdural. Believe me, my friends, if you have this concept, you can avoid proximal control, distal control of vertebral artery has been described very elaborately. These tumors can be removed very quick time. And you see, this is C2, this is trigeminal, very similar. This is C2 C2 neurinoma, this is trigeminal neurinoma. Just behind the atlantoaxial joint, no laminectomy. No bone work, open the dura, work within the dura, break into the tumor. Here there is no problem of even if you damage the nerve of the C2 ganglion, there is no problem. But try to avoid, and you can save the C2 nerve function. Work within the dura and you can have a beautiful resection. Now I want to talk quickly on chordomas. Chordomas are extradural tumor. They respect the mother dura. They break the bone, they destroy the bone, they demolish the bone, but mother dura remains intact. They displace the soft tissue. They break the bones, but never transgress the soft tissue. So the cavernous sinus is on the dome of the tumor. Carotid artery is anterior to the tumor. This relationship is absolutely beautiful and has to be understood. You see, this is extradural tumor, subcavernous sinus tumor. If you have this, you see, in 1995, I produced one of the most fascinating papers on the subject, that carotid artery is not here. Carotid artery is not here. It is displaced anteriorly. And you can work in this territory without the fear of carotid artery. And I published this middle fossa subgastrian ganglion approach. Beautiful approach for clival chordomas, petroclival. Of course, when the tumor goes in the nasal sinus, you can have another approach. You have carotid artery anteriorly, dura here, come from lateral, open transversely, work, and these are soft tumors, these are jelly-like tumors. You can demolish the tumor in quick time, and you can have a fascinating clinical outcome. This is the tumor, and this is post-operative. I just want to show quickly the intraoperative. So you can do transnasal surgery for some tumors which go into sphenoid sinus. You can use endoscope, but transcranial route is so, you see, this is carotid artery inside the cavernous sinus. You can work on the clivus. You can have the control on the sixth nerve. You can have a beautiful exposure and a beautiful tumor resection under direct vision. We recently described supracerebellar approach for clival chordoma. This is a beautiful approach for these tumors which have very predominant posterior fossa extension. Supracerebellar, open the dura, identify the sixth nerve, work within the dural confines and resect. Quick resection, no major bone work, and you can do a beautiful resection in quick time. You see this clival chordoma, which is predominant. You don't want to come from the nose. You don't want to come from lateral. You come supracerebellar, work extradurally. From dura, open the dura, work, identify and save the sixth nerve. Sixth nerve is displaced on the dome of the tumor, on the upper dome of the tumor. Work inferiorly, work on the dome at the later stage of operation, and you can do beautiful dissection with a minimum exposure and quite a radical tumor resection is possible. Nasopharyngeal tumors, angiofibromas are extradural and extracranial. And you can develop a beautiful plane of dissection by working with blunt dissection. Initially, these are nasopharyngeal angiofibromas. You know, it can be difficult tumors, dangerous tumors. They also go on both sides of the bone, but dura is respected. Dura is respected like anything, and you can make this tumor. These are extra cavernous sinus tumor. And I had described transcranial route for the first time in 1994 for these tumors, but I do not do nasopharyngeal angiofibromas by transcranial route. You can have epidermoids in the cavernous sinus. Extradural route is beautiful. You can have aspergillomas. Mucormycosis during COVID time has been very, very common thing. Those are difficult issues. You can have tuberculomas in the cavernous sinus. Briefly, I will go small. Ahmed, do I have 5 minutes? Ahmed, 5 minutes?
Professor,
Do I have 5 more minutes? Then I want to talk briefly on cavernous sinus meningiomas.
5 minutes. Yes.
Okay, okay, thank you. So cavernous sinus meningioma means tumor of the mother. And these tumors, you see, like convexity meningioma, superior sagittal sinus is not involved. Here, superior sagittal sinus is involved. Superior sagittal sinus is involved. These tumors are more aggressive tumors. When the frontal sinus is involved, when the tumor goes extracranial, they are more aggressive in nature. And when the tumor is extracranial, it is more aggressive in nature. Similarly, when the tumor involves the cavernous sinus inside, it is more aggressive inherently. That concept we have to understand. See, if the tumor is only on the lateral wall of cavernous sinus, it is relatively benign tumor. When the tumor goes in the cavernous sinus, it is relatively aggressive tumor. When the tumor goes into the sphenoid sinus, it is much more aggressive, like a malignancy. You see, when the tumor is intracavernous, like superior sagittal sinus tumor, it is inherently more aggressive. You do a radical resection, there are possibilities of recurrence. You see, this is another tumor, completely intracavernous sinus meningioma. Possibility of recurrence is there. When the tumor goes in the sphenoid sinus like this, it is a malignancy, and you should talk the tumor in a malignant fashion. You see, and operate like a malignancy. This tumor is arising from the lateral wall of cavernous sinus. This is more benign tumor. Arising from the vascularity from the posterior wall of cavernous sinus, more benign tumor. You see here, this is vascularity from the posterior aspect of cavernous sinus. You resect them and you cure them. This tumor, another one from the lateral wall, not going in the cavernous sinus, very straightforward tumors to operate. Initially, in my experience, I was much more aggressive, much more wider in my exposures for cavernous sinus, for petroclival, facial nerve mobilization, petrous bone drilling. But now my conventionality, more and more experience, conventional approach like Sami has described. I introduced the concept of supracerebellar route for petroclival meningiomas. You see, supracerebellar, this is the first paper on the subject. And I have removed several tumors like this from a supracerebellar route. And I think this is a beautiful route for even for the tumors that go into the cavernous sinus. And you can have a tremendous, you see, these kind of tumors, you don't have to come transpetrous and all those things. You cannot get into the arteries. You have to save the arteries early in the operation, and you can do a beautiful resection. Sometimes you can have some difficulty in removing the cavernous sinus part of the tumor, but that is, you have to know how to do it. So tuberculum meningioma, I published this series in 2003. Now my experience is more than 300 cases. Olfactory group, this is the largest published series on olfactory group meningiomas in the world. Essentially, for meningiomas, curing is a non-issue in the treatment of meningioma. Recurrence of meningioma is independent of extent of tumor resection. It is not the treatment, but cellular behavior of meningioma that decides the outcome. Thank you very much, my dear friends. And I must say that I am very happy and very proud to be presenting my material before Yemen neurosurgeons. And I'm sure, and I want, and I wish that Yemen neurosurgery becomes the best in the world. I wish that you should not have excuse that war is going on, I am sorry. This is going on, I am sorry. We have been provided by a platform where we can have webinars from every neurosurgeon in the world. There is no way you can say, oh, I cannot go to America, cannot attend this meeting, I cannot do this thing. Of course, you can go to the cadaver lab. Of course, you have several patients where you can do operation. My best wishes to you. And Dr. Ahmed, thank you very much.
Thank you very much, Dr. Goel. We are very honored and pleased to have you with us in our conference, and very nice presentation and very nice cases. Due to limited time, we have one question from the chat for you, Dr. Goel. Dr. Nas Al-Shwaish, he is asking, how do you control cavernous sinus bleeding?
We have to control not only cavernous sinus bleeding, we have to control bleeding from any place. We have to control venous bleeding. We have to control arterial bleeding. We have to respect blood. Blood has to be respected. We have to learn the art of respecting and controlling bleeding. That is our subject. Essentially, cavernous sinus bleeding cannot be controlled by coagulation. Cavernous sinus bleeding has to be packed with Surgicel. Wherever there is, you have to identify the exit sites of veins, where the veins enter, you have to know, and then you have to pack those sites with Surgicel. Like tentorium bleeding, you cannot coagulate tentorium bleeding. You have to pack with Surgicel. So you have to have special experience in controlling bleeding from special sites. And that is the answer to that question.
Dr. Goel?
Yeah.
Doctor, we have enjoyed your lecture and we are honored to have you with us.
Thank you very much.
Now we have Professor Henry Schroeder from Germany. Dr. Schroeder.
Yeah, hello.
How are you?
Sorry that I'm late, but we had, as usual, we have an emergency when you don't need it.
Okay, no problem, sir. Thank you.
Can you see my screen?
Yes, everything is good.
Yeah. So I want to thank the German Society of Neurosurgery and especially Ahmed for the kind invitation. It's a great pleasure to be here with you. And I hope we can discuss some issues of endoscopy. So Ahmed gave me the title of role of endoscopy in interventricular tumors. Is there a role of endoscopy? And I can say, yes, of course, there is a role of endoscopy. And now I want to convince you that you are convinced that it's very good. So interventricular tumors may occur everywhere in the ventricular system, in the lateral ventricle, in the third ventricle, and in the fourth ventricle. Sometimes they block foramen of Monroe or they block the aqueduct and cause some problems. When we use an endoscope, purely endoscopic technique, we have an underwater surgery. That is a problem. If you have a tumor which is bleeding, it easily disturbs your view, and that might be a problem. So what are symptoms? Most of the intraventricular tumors become symptomatic because of blockage of CSF pathway causing hydrocephalus. So we have headache, nausea, vomiting. Sometimes they cause neurological symptoms depending on the location, and sometimes they become symptomatic with seizures. So what is the treatment goal in interventricular tumors? Of course, the main goal is, if the patient is symptomatic with hydrocephalus, the restoration of the CSF circulation. And for that, endoscopy is an ideal tool. Then, of course, we want to have the histological diagnosis to initiate the right treatment. Or, if appropriate, we can also aim for a complete tumor resection. So what are factors which are influencing our approach? Of course, the size of the ventricles. If you have slit ventricles, it makes not sense to approach a tumor. If you have wide ventricles, it's ideal. Normal ventricles are okay. Tumor location is, of course, a major problem. Tumor size, vascularity, individual anatomy, aim of the surgery, and of course, the surgeon's experience and preference. So what we use for interventricular tumor surgery, when we make a pure endoscopic approach, we have a special ventriculoscope, the lotoscope. This is a standard scope. This is a smaller version with a smaller diameter. So this is mainly used for small ventricles, or when we want to make an ETV and just a biopsy. And this is when we want to resect tumors in larger ventricles. So for me, very important is to have this endoscopic sheath, because this can be used as a retractor. Sometimes I use it for hemostasis, and sometimes I use this to create a space. I go with my tip in the sheath a little bit backwards, and then I have this space in front of the lens as my working space. So here's, for example, there's a tumor in the frame of Monroe in the third ventricle. And I cannot expose it well because here is a fornix. So I go in and I carefully displace the fornix, and then I have a good access to this lesion. Hemostasis is critical. So what we have for hemostasis, of course, simple irrigation, bipolar forceps, and the bipolar diathermy probe. When we irrigate, usually we have just a syringe. You can also take an automatic pump, but most of the time it's not necessary. We have just a syringe. The tube is connected to the ventriculoscope irrigation channel, and then we clear the view. Or we have the bipolar for coagulation of vessels. This is also a very effective instrument. It can be used for choroplexus coagulation, but also for coagulation of bleeding tumor vessels. And then we have a technique which one of our fellows coined as the small chamber irrigation technique. That means if you have a hemorrhage, we start with irrigation. Then we try to approach the lesion where the bleeding is originating. And then if you have identified it, we go with the endoscope back into the endoscopic sheath and create a small chamber. And this small chamber can easily be cleared from blood. So we have a good view, and then we can achieve coagulation. This is one example. You see the colloid cyst. There's a small artery attached to it. We have a bimanual technique. So I pull the cyst to get access to the small artery, and then I coagulate it. And I coagulated really several times, and I thought this might be okay. And then I took a scissors to cut it. But you see, oops, too early. The vessel was not properly coagulated. And then it happens that you don't see very well, easily. It takes only a few seconds and you don't see anything. So we have to irrigate to clear the view. And then I go with my endoscopic sheath close to the lesion. So I have to go into the foramen of Monroe. And you see now I go back with my endoscope into the sheath and I create this small chamber in front. And this is a small space which can easily be cleared from blood. If you try to clear the lateral ventricle, it will not happen because the space is too large. And you see here now I retract with the endoscopic sheath the fornix because I have to go to the tela choroidea at the roof of the third ventricle. And only then I can coagulate this blood vessel. So I think it's quite helpful technique in certain instances. If you have a severe bleeding, then we use a dry feed technique. We have first described this in 2002 in our series of colloid cysts. And then Joachim Oertel from Hamburg put together 6 cases where we use this technique as well. And that means we use this technique when we have a hemorrhage and we cannot clear it with irrigation. Also not with a small chamber irrigation technique. You see the colloid cyst, there was a misunderstanding between me and my assistant. He should just rotate, but he pulled. And then you see what we call the Japanese flag. Everything is red, you don't see anything. So we start with irrigation, but it became very clear very soon that this will not stop the hemorrhage. So what we use then is a catheter and simply suck off the CSF. See, this all bloody CSF is removed. And then in most of the cases, the bleeding stops. If not, you can take a bipolar and you can get the hemostasis then. So this is the effect if you don't want to switch to microsurgery. And you see, after we get it clear, we could continue with the resection of the colloid cyst without any damage to the veins or the fornix. So this is our setup. Usually we fix the endoscope with a holding device because I don't want it to have freehand and I don't want that an assistant is using holding it, because if you're in the foramen of Monroe and you make unintentional movements, you may damage it. It's different to the nose. In the nose, you can move it and nothing will happen. Then with the left hand, we guide the endoscope left, right, in, out. And with the right hand, we just control the depth of the instrument. Navigation can easily be adapted to the system. So you have always a good trajectory where you go. And this is our setup. When we are sitting or sometimes we're standing, it doesn't matter. It is like what you like most. So lateral ventricle tumors. When you have a tumor in the lateral ventricle, of course, you can directly approach them, shortest way, but sometimes it's better you make a longer way because you need some space in front of the tumor. If you have no space of the ventricle, sometimes difficult. So that's why it's always good to have some space. So this is a good example. You see, this is a 70-year-old lady. She has hydrocephalus on one side, confusion, and she has two lesions here. One is at the foramen, one is here. So what we do, first we go in, identify here. So foramen is concluded by tumor. Then we make a wide subdostomy to have a communication between left and right, and then we take a biopsy. And as expected, in ventricular tumors close to the ventricle, 70-year-old lady, multiple spots. It was a lymphoma, and she underwent oncological treatment. And you see the hydrocephalus resolved, and her symptoms were completely gone. So it makes it very easy. No need for stereotactic biopsy, no need for shunt, just endoscopy. The next case, this was a 65-year-old gentleman with an incidental finding of a tumor in the lateral ventricle. And in the follow-up MRI, the tumor was growing. So he decided to have it removed. So what can we do? We can do a transcallosal approach. That is a good option in this way, small ventricles. Or what we did, we just went with an endoscope directly into the ventricle. You see, the tumor is not very well vascularized. That is good. And it seems to be attached to the head of the caudate nucleus. So neuronavigation for planning, introduction of the endoscope. And then you see this is a tumor. It's not very well vascularized. It is a very good candidate for endoscopic surgery. And you see now I use my endoscopic sheath as a retractor. So I push the tumor away from the head of the caudate nucleus and I detach the tumor. Many people make a piecemeal resection of these tumors and then they state, oh, it takes too long and it's time consuming and it's not effective. That's why it's not good to use an endoscope. But you see here, we use the endoscopic sheath to displace the tumor from the head of the caudate nucleus. We deconnect the tumor with bipolar coagulation. And then we detach the tumor. So we don't make a piecemeal resection. We just detach the tumor from the ventricular wall. See, a little bit of hemorrhage occurs. So now I use the endoscopic sheath as a retractor. So I push the tumor up. You see foramen of Monroe. It's free, but here is a hemorrhage. So with irrigation and retraction, I localize the bleeding vessel. And with a bipolar diathermy probe, we coagulate. And then you see, I can take this as one piece. The tumor is not fitting through the endoscopic sheath, so I have to remove the whole system. Endoscope, endoscopic sheath, and then I can pull the tumor through the cortical puncture channel. And that's why it's a very quick surgery because I took it as one piece. Of course, if you make a piecemeal resection, this takes a long time. So that's, of course, not so a good idea. It was a subependymoma. Then there's a lady with a larger tumor, dilation of the left ventricle, lateral ventricle. You see, it's not too much enhancement. So we thought, okay, we go in. But when you look with an endoscope, you see now it's a reddish tumor, a lot of blood vessels. What to do then? So we introduce the endoscope. Of course, we start and try our best. Coagulation of the vessels. See, it's also detached to the septum and also to the caudate nucleus. And you see, we take a biopsy and immediately it starts to bleed. Then we try to get hemostasis, irrigation, bipolar. It was not working. So what we do then is the dry field technique. So we removed all CSF. The tumor is soft, so we just took a suction to remove it and a grasping forceps, but then it turned out to be too time consuming. So I replaced the endoscope with a tube. So we remove the endoscopic system and then we just follow the endoscope tract into the ventricle. This is 70 millimeters. And then you see how easily you can resect it. And the bleeding, which under an endoscope is a catastrophe, is now easily managed by microsurgery. So if you have a tumor and you start with it and you feel it is not working well, it takes too long time because the tumor is too firm or you have too much hemorrhage, there's no problem. You just remove the endoscope and then you follow the endoscope track with this tube, and you can dissect by manually under the microscope the tumor. Or you can also use an endoscope through the endoscopic sheath, through this sheath. It's up to you. But here you see in this case, I just took the microscope. You see, we could get a very good resection with a neurocytoma, and she is now out of the surgery for 5 years and so far no recurrence. And you see the tract which we create with the tube is not so much, so it's not big damage. So the tubes can be taken as an alternative. And you see here, you use the microscope, but you can also use an endoscope via this tube. It's up to you. So this is another example. It was a 35-year-old female. She became symptomatic with headaches in several months, and then she hit a seizure. And you see MRI shows a huge tumor in the right lateral ventricle, and the diffusion-weighted images shows a restriction of diffusion, so hyperintense signal in B1000 image. So what is the best approach? The best approach is always in the longitudinal axis of the tumor, and that would be that way. And you come from here, you could go through the septum, but this makes no sense. So we just plan the approach to come from the precuneus area directly into the tumor. So this is a positioning, neuronavigation. And again, under navigational guidance, the tube is introduced into the epidermoid. I think it makes no sense to try and ventriculoscope because the tumor is too firm and it will be too time consuming from the beginning. So we just use the microscope, resect as much of the tumor as we can, and then at the end, we switch to the endoscope to look for residuals. And here's some tumor remaining, and this is then resected under endoscopic visualization, a small piece attached to a big vein we left intact. So the tube is removed, and then usually we close the cortical incision with fibrin glue to prevent subdural CSF accumulation. This is quite helpful. And you see this is a small remnant which we had to leave because of a vein. Otherwise, we have a good resection. If you see such a tumor in the lateral ventricle, you see there is no ventricle. Of course, this makes no sense to use an endoscope, at least in my mind. So here we make a transcallosal approach and resect this tumor. Third ventricle. There are a lot of approaches where we can go to the third ventricle. Endonasal sometimes, lamina terminalis, transcallosal through the foramen, through the telechoroidea. We can come transtentorial from the paramedian approach, or we make a supracerebellar infratentorial approach. So many options, and depending on the lesion. In many cases, we just make a third ventriculostomy. You see, this is a young girl becoming symptomatic with this chronic hydrocephalus, and you see here, it's a small tactile glioma. You see here, tactile glioma. And what we do here is, we just make a third ventriculostomy. To save some time, I will skip it, but we just make a ventriculostomy. We don't take a biopsy. For tactile gliomas, no need to take a biopsy. You just make follow-up, and these are very benign tumors here. And you see after the ventriculostomy, you have a very good flow void, and the symptoms improved markedly in this girl. Sometimes we go directly to the lesion. For example, if you have a tumor which is occluding the aqueduct, you see a very small tumor, patient becomes symptomatic because of hydrocephalus. So we go from a trajectory behind the hairline straight to the aqueduct. And you see it's a very small tumor occluding the aqueduct. This is rare that you have such a small tumor because you don't become symptomatic, but this is exactly in front of the aqueduct, and that's why it's causing hydrocephalus. You see posterior commissure, habenular commissure, and this is a roof. So we start with the biopsy. There's some hemorrhage, but not much. Can easily be controlled with bipolar coagulation. And then the tumor is stepwise resected. And in this case, we were able to get a gross total resection because it is a small tumor. See, the aqueduct becomes free. And then finally, tumor is completely gone. And it turned out to be an ependymoma grade 2. When you see hydrocephalus resolved, patient is doing fine. These small tumors are rare. It's not frequent. What is more frequent is that we make an ETV and we take a biopsy. Can this be done from one borehole? Usually yes, but you have to look to the size of the foramen of Monro. If it is of adequate size, we place the borehole not exactly precoronal, what we use for the ETV, but we go 2 centimeters in front. Then we have a trajectory. It's not ideal for the floor. It's not ideal for the aqueduct, but you can manage. If you tilt the endoscope carefully, you make a certain colostomy and takes a biopsy. If the foramen of Monro is very narrow, then please don't do it. Then you need a flexible scope or you make 2 boreholes. Otherwise, you will destroy the foramen. You see, if this foramen of Monro is there, you see the floor, you see the aqueduct. If you have the small one, then you need 2 boreholes if you have just a rigid scope. One example, patient, tumor here, pineal region. You see the gyrorelief is flattened because of the hydrocephalus. And then we make an ETV, take a biopsy, you see hydrocephalus resolved. And then depending from the histology, you can make the decision. Is this a germinoma? You go just for oncological treatment. If it's a benign tumor or a pineal tumor of intermediate differentiation, then usually we make a resection via intratentorial supracerebral approach. An example, this was a 20-year-old, no, this was a patient, he had not seizures, he had the visual problems. And you see here, it's an unusual tumor, but very small ventricles. So you could do a biopsy from this approach, but we thought if he needs radiation soon because it's a malignant tumor, then we get easily a CSF leakage. If you take a nasoceptive flap, it takes a while until it's healing. So that's why we just make the decision to make an endoscopic neuronavigational guided biopsy. Although the ventricles are very small, but you see with navigation, you can go into the ventricle. This is a little laparoscope. And you see here is the 3rd ventricle. And you see here easily the tumor on the roof or on the floor of the 3rd ventricle. So we go in now with the endoscopic sheath. We have control over the sheath because we go with the endoscope a little bit inside the sheath, can displace the fornix a little bit, and then we are in front of the lesion. And then we take a biopsy, and this turned out to be a germinoma, and he underwent oncological treatment, and you see the tumor is completely gone. Unfortunately, his visual problems did not improve very much. So he has still some visual problems, but otherwise he's doing okay. So just a biopsy in small ventricles is possible when you have neuronavigation. Another example is of a 5-year-old male. He had seizures and headache, and he had this huge tumor. And then he came to us. You see, this is 19/6/15. Alpha-fetoprotein was increased, so obviously a malignant tumor. And you see 1 week later, immense growth of the lesion. So we make an ETV to treat the hydrocephalus and the subdostomy. And then immediately after this, our oncologist started with chemotherapy, high-dose chemo, and stem cell transplantation. And then the tumor still grows a little bit, and then it stopped. So it's a large tumor bulging into the foramen of Monro on the right side. So what is the best approach to get to this tumor? Oh no, he developed hydrocephalus in between, yes, because the septostomy was closed and the foramen of Monro were blocked on both sides. He had shunt, and you see how large a tumor becomes. And then this was the end of the chemo. And then, of course, we have to make surgery. You see the bulging is even more. So we thought the best approach for this is a transcallosal approach through the foramen of Monro. So transforaminal, transcallosal, transforaminal. You see transcallosal, transforaminal. So we did the tumor resection. We place the patient so that this the hemisphere can fall down by gravity. And you see here, this is a tumor in the foramen of Monroe. So we coagulate the tumor surface. And then you see some hair is inside. Then one tooth, it's a typical teratoma, different kinds of tissue. And then we evacuate the cystic part. It's a very fibrous tumor capsule. We try to decrease the size of it. And then we have a good plane to going around. See, this is all tumor, and we can dissect the gliotic plane around the tumor from the third ventricle. You see, very good plane here. We dissect the whole tumor. And then it can be removed. And then there was a blind corner to look to the talar. You see, here's a telachoroidea with coral plexus, but I could not see very well, is this all removed or not? So we used an endoscope to inspect. This is a subventriculostomy. We open a little bit more, and then we take an endoscope to go into the lateral ventricle to see the veins. And then we look here. This is the roof of the third ventricle. This is the origin. But here is just coral plexus. So it seems to be removed. This is a boy after surgery. There was a malignant teratoma, cross total resection. You see, this is a transcallosal approach, just 1 centimeter. And it's now 6 years later, no recurrence, and he's doing fine. Another interesting case was a 29-year-old male, headache, fatigue, decrease in performance. And he has a partial pituitary insufficiency. And you see a huge tumor in the third ventricle, midline, a little bit hydrocephalus already on the right side. And you see the tumor is filling the entire third ventricle, all tumor here. So we discussed what approach is the best. When we make our courses, most people say, yeah, transcallosal, and then transchoroidal. It is an option, but you have really opened it widely because your tumor is here and tumor is here. And the longitudinal axis of the tumor is from here to here. And in this case, it is very nice to see this is a chiasm, prefix chiasm, and this is a gland. So you have more than 1 centimeter space. This is very unusual. Mostly the space is smaller. Here's again chiasm, and this is a gland. And that's why we made an endoscopic endonasal approach, transflatum, transtuberculum. You see this is a gland, carotid, optic nerve left, optic nerve right. We open the arachnoid, and you see all this is stalk. This is not tumor capsule or so. This is all the infundibulum. It's just a dilated stalk. So you have to find the right plane. Ultrasonic aspiration is used to reduce the tumor in size. And then you see we have to find a good plane. And this is all the infundibulum. There's a good plane. And then I used the 45-degree endoscope because the tumor is not coming down. 45-degree endoscope, and then we can dissect this gliotic plane around the tumor. So it's ill-advised if you just pull. You have dissected. Of course, in this case, we have the advantage because we have a large space between gland and optic, but here it's possible to make a traction, counter-traction technique and resect it. This is the upper part of the tumor. It's still sticky, came not down, so I had to bend my suction to get it dissected under view of a 45-degree endoscope. And only if the tumor is completely dissected from the surrounding tissue, then we removed it.
Dr. Schroeder?
Yes.
5 minutes, please.
What?
You have 5 minutes.
Yes. Yes. So complete tumor resection, 8 years after surgery now. He needs full suppressment of the hormones, also DI, but he's not becoming obese and he's doing fine. So for the fourth ventricular tumors, the role of endoscope is limited in my opinion. usually we make an ETV, sometimes we take a biopsy. But tumor resection directly, it's not a good idea because there's no space. And if you go with an endoscope directly into the tumor through this hemisphere, you might damage the dentate nucleus. So for these cases, we usually make a televelar approach, cut the tela and the velum and the velum medullary inferiors, and then you have a good approach to see all of the fourth ventricle. So for this, it's not a good indication. So we reported about our experience with endoscopy techniques already in 1998. We're one of the first who described it, and then we gave an update in World Neurosurgery a little bit later. So if somebody is interested, so which and why and which we use the endoscope. And when we have small ventricles and we have a tumor resection, microscope is better transcallosal approach. The endoscope is more useful in large ventricle, but you have seen also in normal ventricles, we can take a biopsy. When we have a small tumor, endoscope is good. If it's too large, it's too time consuming in many cases, then you use, of course, microscope. If you say tumors are highly vascularized, it's better with a microscope. If they're poorly vascularized, endoscope is fine. Soft consistency, of course, endoscope it's an option. Firm consistency, usually microscope. And fourth ventricle, I would always take the microscope except for ETV. And third and lateral ventricles can be approached with an endoscope. So the inclusion is that ventricular approaches is an individual decision-making. Endoscope, usually when there's a hydrocephalus and biopsy, or when we have small lesions, we can be effective also with a purely endoscopic approach. For microsurgery, usually we make transcallosal approach, but if you have large ventricles, then we make a transcortical with a tube. And fourth ventricle, usually microsurgery via televelar approach. Thank you for your attention.
Thank you very much, Professor. Very nice presentation and very nice lecture. We have two questions. One from the chat. Do you apply fibrin glue to the cortical incision or to the stitch dura?
I cannot understand. It's not loud enough. Can you repeat the question? I don't get it.
It's written from the chat. Do you apply fibrin glue to the cortical incision or to the stitch dura?
No, this is cortex. We close the cortical incision, we make it narrow, and then we place fibrin glue to prevent that all the CSF comes out. And then sometimes in these interventricular tumors, you have a lot of subdural collection. To prevent this, we use fibrin glue.
Another question regarding the outcome and complications. What is the difference between dry technique and irrigation technique?
Please repeat. It is very light. I cannot hear it. I have my speaker full power. Please repeat.
No, we've had a problem with that before.
Dry technique and irrigated technique in the intraventricular regarding outcome and complications.
Sorry.
Dry technique and
Can you get close to the microphone, Ahmad, please?
John, can you repeat the question for me?
I can't even understand it myself, Dr. Schroeder.
Oh.
Dry field technique. Dry field technique.
Yes.
Suck up the CSF and the irrigation technique with water, underwater technique.
Yes, the dry field technique we use when we have severe hemorrhage. You have seen there was a lot of bleeding. It was just a venous bleeding, but for endoscopy, it's a disaster. When you have it in microsurgery, you don't take much care. You take a suction and then it's done. But for endoscopy, when there is a major bleeding, then the dry field technique is better. The small chemo irrigation technique is for less severe hemorrhages.
But is there any difference in outcome or complication?
No. We had no problem with the dry field technique. When you are very careful, of course, when you suck down along the sheath of the endoscope, you must be careful. When you go too deep and you suck too much and you have the fornix in front of you, that might be damaged. So you have to be very careful when you go down and don't take too much suction, not too strong. Otherwise, you can suck some of the contents, choreplexus, vein, or fornix. Of course, you have to be careful with it. But I found it very helpful. So we had not the the feeling we have to switch over to a microsurgery in these cases. But this was mainly occurred in colloid cysts. When we have a tumor which is bleeding a lot, but like a case I showed you, the second case, then we switch over to microsurgery because the bleeding will not stop. If the tumor is too vascularized, I think it makes no sense with an endoscope.
Thank you very much, Professor. We enjoyed your lecture and we are honored to have you with us in our conference. Thank you.
Thank you so much again for the invitation. I wish you more successful talks.
Thank you very much. Now, Dr. Adnan will introduce, Dr. Salim.
But now, Professor Salim Abdul Rauf, the founder of Abdul Rauf University, USA, and he will give us the improving patient outcome in the treatment of complex vascular lesions.
Thank you so much. It's my honor to be with you all. It's great to see the Yemen Neurosurgical Society attracting some of the biggest names in the field of neurosurgery in the world. So that is really, great what Yemen neurosurgeons are doing, and it's great to see that. I see many of the colleagues, experts in every area of neurosurgery here, and I'm honored to be on the panel with them. What I'm going to talk about today, what I would ask to speak about, is how we can improve patient outcomes in vascular neurosurgery. There is a lot of work going on in endovascular that is improving techniques in endovascular. I want to share with you what we're doing in microsurgical world to improve techniques and outcomes. Essentially, I'm going to only show two cases to make my point, and especially I'm talking about the concept that I have introduced to the literature, which is extending the awake surgery from glioma and functional work into the complex vascular work. So this is a patient.
We present a case of a 58-year-old.
So this is a patient, 58-year-old, basilar apex aneurysm, who presented to a hospital, and they tried to coil this aneurysm, and they could not do it. As you will see here, it's a wide neck aneurysm, and they tried to coil it, and the coils wouldn't stay. And of course, any attempt of stenting that requires anticoagulation is not recommended in acute hemorrhage. So they sat on the patient. He came from a different part of the United States. I got called, said, listen, we are concerned about this guy. He's ruptured. We have not been able to endovascular treat it. So he was sent to me in a delayed, in a fashion, and a couple of weeks later. So this is a challenge, and I want to speak to you. What's the advantage to the way we are doing this here? Okay. So as we come here, so that's so you see, it's like a box. It's rounded, and unfortunately on CT scan, it has calcification in it as well, which makes these things, of course, high risk. Of course, we look at the posterior clinoid and the clivus and see the distance. So this is an ideal case for a transsylvian approach instead of a middle fossa or subtemporal approach. Okay. Okay, so our plan is to go transsylvian, and I want to show you the challenge we had and how we address that challenge. Okay. So anyway, this patient is on a Veni mask. We're going to remove that in a minute. He's not intubated. This is just an oral mask. He's very sleepy for the beginning of surgery, so he doesn't feel the pins or anything. Now we're going to show you the challenge I'm facing here. Okay. As I get through this is a temporal lobe. This is a frontal lobe. This is a posterior communicating artery here. Okay. It's right in our way to expose the basilar apex. Okay, and I'll show you what the issue here is. So as we come down here, so here, this is a posterior communicating artery. Okay, of course, he's had blood in the cisterns. Okay, so I'm just opening that area. The PCOM is right in my way. All right. You see, I'm starting to see the aneurysm that's calcified, okay? Clearly, I have no access to the whole aneurysm or its neck with the PCOM in my way. Now, traditionally under general anesthesia, we make a tough decision to sacrifice a posterior communicating artery. But to be honest with you, those of us who've done enough vascular work over the years know that once in a while you can have a disaster from that without knowing. So I'm gonna know 100% for sure whether I can sacrifice this PCOM. Okay, so let's do that.
So I'm proceeding with a test occlusion of the posterior communicating artery by placing a clip.
Now what this is essentially—
Here we introduce the concept of awake clip test occlusion. The patient is now taken out of conscious sedation, is awake and responsive. We have just placed a clip on the posterior communicating artery. We will do a 10-minute lunge.
Squeeze your left hand. Squeeze my hand.
Okay, for 10 minutes, I'm going to check all the functions, including upper basilar function, make sure that there is no issue here. So, you know, we're checking vision, we're checking motor and everything.
Good, good. All right. Wiggle your toes for us. Wiggle your toes. Wiggle them. Okay.
Now,
Once
after
the
10
patient
minutes,
has-
the reality is based on my experience on these awake cases now, you would know within 60 seconds, but I do 10 minutes just to be on the safe side, okay?
The occlusion test. Now we are proceeding with occluding and sacrificing the posterior communicating artery. This using micro scissors to cut through the artery with 2 permanent clips, mini clips on the PCOM. You will see as we mobilize the amount of space we have gained now access to the basilar apex.
You see, it's a very difficult aneurysm.
Calcified aneurysm. Critical in all basilar aneurysms to look behind the aneurysm, especially look for perforators. Here, I am bipolar coagulating the back wall of the aneurysm to shrink it and to create more space to make sure that we do not incorporate a posterior thalamo perforator into the clinic process itself. Once I have assured that I have space, I can see I'm placing the permanent clip. I'm looking at the contralateral P1, as you see at the tip of the clip. I move the clip up just to make sure there's no occlusion of the P1. Very slowly, I close the clip.
Now, this is so we talked about 2 things. You know, one was the issue how to sacrifice a vessel, in this case, a PCOM with 100% testing. The second issue is that I'm placing a clip in the upper basilar. There are all these perforators behind us that you cannot see sometimes as well. As I close a clip, I'm testing the patient, okay? So what I'm able to do here, which you cannot do under general anesthesia, because EEG, SSAP, motor evoked potential do not test perforators of the posterior thalamo perforators. These affect your consciousness, many things. This is where the risk of basilar aneurysm surgery is very high. There is no way you can test that 100% with intraoperative monitoring. These 2 steps were a game change in this case, okay? And that's the point I'm trying to make, why this kind of advance in vascular neurosurgery can make a difference. Okay. I'm talking to the patient, everything is fine.
The patient did well. He was discharged home, post-operative day number 4.
He was delayed case, so he was able to be discharged.
In a delayed fashion. And this is his picture from his.
Okay. The next case I want to talk to you, the 2 cases I'm showing you, they're not cases that are treatable endovascularly.
27-year-old male with a large, partially.
So here we have a partially calcified, partially thrombosed large aneurysm, okay? This is a
calcified part into the bone will become an important part of operative.
You see, it's only partially filling, which is a bad sign.
Aneurysms are by.
Okay. So you see that's the actual angio picture, which is always a very high risk sign. In this case, the aneurysm is attached to the bone, which we have to be very careful about. And I'm removing that piece of bone that's stuck to the aneurysm separately to be on the safe side. Okay. As you see here, I was ready with the STA in case I had to do a bypass, because this is a, you know, a case that we don't know how things are going to go. Okay. Now we're opening the dura. The dura is completely attached and stuck to the dome of the aneurysm. Okay. So I'm just gonna, with the time, I'm gonna just advance this a little bit. So in this case, there is no way we could put a clip on the neck of the aneurysm. So we have to open the aneurysm itself. So I'm needing to use a 15 blade to essentially open the dome of the aneurysm here. Okay. And now I'm needing to use a CUSA to really, so this is the mouth of the aneurysm. What my goal is, I'm very worried if we do any clip manipulation here, part of this can enter the MCA. So I want the blood from the MCA coming at me this way, pushing any potentially embolic phenomena, okay? So this is the idea in an aneurysm like this. So I'm CUSAing this until I get to the mouth of the aneurysm here, okay? And that's why, and you will see, I mean, I'm talking, see, as long as the patient is doing okay and my main vessels are okay, I'm feeling very comfortable with this, okay? As we come closer, you see, now I'm closer to the neck of the, neck here, and I know this is where the problem is. As soon as I see the blood, I feel good that now I'm pushing everything towards me, okay? And not the other way. By putting clips here early, you will fracture some of this thrombus and push it as an embolic phenomenon. That's why that is never a good case and never a good idea in an aneurysm like this. And that's a strong recommendation I'm making. So now as the blood is coming at me, now I would temporarily occlude the aneurysm with multiple clips until I make sure I got full reconstruction. Now this is where the awake testing is important. I want to make sure I'm not occluding any perforators behind the M1. I want to make sure that the other M2s are open, okay? And I want to do the slide here, and I'm talking to the patient.
Good.
He's doing very well. I'm very happy. I've occluded the neck. So this is how, these are the steps with awake testing are a game change, because these are reversible steps that you can reverse.
27 when I had surgery. I was scared. But Salim Abdurrauf, he made me and my family feel safe. If it had been anyone else, I don't know if I could have done it. So I guess I owe you a thank you.
What
For me and my
patients
family,
say
we
mean a lot
appreciate it.
to all of us.
The surgery really
this
was
is
life or
important.
death for me. And you gave me life again, man. Thank you.
And that's him with his little daughter. All of us are very proud of, taking people through very difficult situations. So you may be wondering, how did we do this? Of course, you have to do this under committee, under IRB protocol to really advance this part of neurosurgery. And I want to just show you very quickly. So I owe you to explain to you how this was done. So the committee approved 4 steps of consent of the patient for the awake option by the surgeon, by the anesthesiologist, by the resident, each one discussing the option with the patient and the family before surgery. The protocol was approved only for complex aneurysms and AVMs. Okay, the reason for complex, their point was that for simple aneurysms and AVMs, the literature, as they reviewed the literature, already had reasonably good outcomes. But the same is not true for complex aneurysms and AVMs in neurosurgical literature. So their point was, if you can show us that you can improve outcome from the published outcome in complex aneurysms and AVMs, then that could be extrapolated to simple ones. But this is where the more difficult, what the literature shows is a more difficult aspect. So this was a period of time the study was approved for. And of course, with the idea that they could stop the study at any point if the arm of the awake was doing worse than the general anesthesia cases. And, they never stopped the study, but that was, of course, an option. Okay. The patient, the contraindications was the patient declines the option, or the anesthesiologist feels that airway anatomy is not good enough if you had to do an emergency intubation. So the anesthesiologist had the complete option to say, no, not this case. Okay. So the committee produced this data last year. As you see, they went through electronic health record, and every patient was looked at. So this is awake arm. So of the 202 complex aneurysms and AVMs I did, 162 underwent awake, which is 80%. Okay. You see all these patients, like this is conscious sedation, all these are the awake patients. Okay. Of course, this is a private information, defining information is redacted. Morbidity, mortality, they looked at every variable. I have to note to my colleagues and neurosurgeons, we're used to reviewing our own data. It is very difficult when you have a group of physicians who are not even neurosurgeons who are looking at your data and going through our patient, but that is the future and we have to accept that, okay? And I'll summarize the data for you here. This is a group of patients that declined the awake option. All complex aneurysms, AVMs, and this is 40 patients, they looked at that. Just to define to you what they defined as complex aneurysms, that was large or giant or partially thrombosed, partially calcified, or those needing EC-IC bypass, okay? That was the aneurysms that they defined. And for AVMs, anything grade 3 and above, okay? So all other simple aneurysms and simple AVMs of my experience in this time is not included in here, okay? So that was the idea of how they want to do it. So we come to the final analysis of this work that I showed you. So what essentially shows is that we went from so this is the general anesthesia cases, and this is awake cases, same team, same surgeon, same everybody, okay? Complex aneurysms, AVMs. So we went from 10% morbidity in the general anesthesia cases to 4.3 in the awake arm. We went from 2.5% mortality to 1.8% mortality in the awake arm, okay? Of course, this is no one person can take credit, an amazing team, people who helped produce this. What I'd like to say, and I want to put humility aside for a second, as I reviewed a lot of articles of the last 2 decades for journals in neurosurgery and of all the techniques that have been introduced in vascular neurosurgery, microscopes, illumination, image guidance, ICG, there's not been a single variable that has made this much an impact on outcome of vascular cases in the literature of neurosurgery. So I'm very proud of this, okay? I know it's something that I'm presenting to colleagues around the world, and that's something that has to have discussion. And I have never said this is the standard of care. I've said this is my results, and so that's really how I look at it from that perspective. Finally, I want to say a word about a new thing that we're doing, which is this research institute for neurosurgeons around the world that I want you to consider for yourself. This is the first time in the field of neurosurgery, we're creating a global research institute under our University of Neurosurgery. Essentially, you neurosurgeons like you have the option to get involved, to become principal investigators of large multi-center and multinational multinational clinical studies in the field of neurosurgery. What our research institute provides to you, because it's very difficult for neurosurgeons to become principal investigators because of tight work, a small patient cohort. So we're providing from our university team of medical students and residents that will work on your project to collect the data, collate it, and analyze the data under you being the PI, okay? So this will provide these large studies in the field of neurosurgery with large teams under a principal investigator. This is our research institute. It has a very sophisticated structure. Of course, we look at, as I just showed you in my own experience, you know, research quality, IRB. I just showed you how committees look at everything. So it's you know, based on all this work, but it's already been done for you. You don't need to reinvent this in your own department, okay? So we have all of that. And so I hope you will take the opportunity to be involved in something like this and do something big. So essentially, this is a QR code. If you want to sign up for potentially becoming a principal investigator of a large clinical trial, okay? This is a QR code right here. And you will submit your, you know, we have some questions for you. You submit your information. If there's an interesting idea you want to look at, we're looking at meta-analysis, systemic reviews, you know, cohort studies, you know, and so forth. So I hope that some of you have some great ideas who want to produce and publish a major paper with teams that we provide to you. Of course, those neurosurgeons who are taking the degree in the University of Neurosurgery, the PhD degree, this is a requirement. It's not an option. But for others, you know, this is an option I want you to consider. And then I just want to say a word to our neurosurgical club, Yemen medical students, an amazing group of students, you know, from a country that has struggled under war for years. What these medical students showed me under the leadership of Ahmed, that what they can do and their limited resources, and they have done an amazing work. I am very, very proud of them. And of course, I'm very proud of the Yemen Neurosurgical Society and me being invited to speak with you among the amazing colleagues from around the world who are colleagues and truly masters who are presenting here. So it's been my honor and pleasure to speak to you today.
Thank you very much, Professor. It's our honor. And you are known for having very active organizations like Abdurrauf Institute and Abdurrauf University, and also, as you mentioned, the Dante Club, who have branches all over the world, including Yemen. We have some questions for you, Doctor.
Please.
Have a question.
Thank you, Professor, for your nice presentation. My question about this awake craniotomy, I think it is so challenging, especially in our low-income country like Yemen. So it is, yes, I think it is less expensive for low-income countries, but I think it is so challenging. So can you tell us about this awake craniotomy? Do you do it from skin to skin awake craniotomy, or you do first initial steps by general anesthesia, after that you convert to the awake craniotomy?
Thank you very much for that question. You raised a critical question that I've been asked around the world. I want to be very, you know, we have to be very honest with each other. I would not have been able to do these kind of cases awake in my first 100 or 200 aneurysms. I was too nervous just to deal with the aneurysm, or the aneurysm is going to bleed, and I'm so focused. There is no way in the world I would have been able to do that awake. This came late in my career. I mean, I had done over 1,000 aneurysm clippings before I did my first understanding of my thinking of the awake aneurysm, right? So unfortunately, I'll have to say this, awake complex aneurysm in AVMs probably can only be done under the hands of tremendously experienced vascular neurosurgeons. We're introducing it to our young colleagues to know how to build themselves toward that direction. But you have to get very comfortable with every aspect of the surgery before you could do it awake. So unfortunately, the awake is, you know, at this point, until people get more experience, it is limited to the kind of the panelists, the speakers we have here, okay? But I think what we're doing, for example, what I've been doing the last 12 months, professors who are my colleagues around the world say, listen, you figured this out, there's a lot of steps, we don't need to reinvent the wheel. I'm going and spending a week or two in their center, they have a bunch of cases, we do them together, I talk about the setup, the question you asked, how you do it, we figured this out, we've really fine-tuned this. Awake aneurysm AVM surgery is not the same as glioma surgery. It's very different from a patient perspective. And skull-based surgery awake is totally different. So I hope for those centers who want to develop this, I'm happy to really, that's part of my institute, what I'm doing. I'm going around the world and re-explaining every step of the procedure. What took us all this time to figure it out, I didn't have this figured out the first few cases I did. It took us a long time to figure out all aspects of awake, complex, skull-based procedures and vascular procedure. So I hope some of you who want to do this in the future, we could do it together, and we will establish that system. For a country like Yemen, actually it's cheaper to do it awake for the following reasons. I have general anesthesia. The patient stays in the hospital much shorter. I didn't show you all the data. The data in our data, statistically big difference between hospital stay between the awake and general anesthesia. So the cost is less for sure. But of course, we need to get to a point where everybody feels comfortable with it. So I appreciate that question. And I want to just say a word to Professor Goel, who's here. When I was first starting this work and I presented it with him in India and stuff, and, he's really supported me. He said, you're doing unique work. I mean, he's clearly he's a world-class neurosurgeon innovator. He saw, this was my early experience. This is just, I just published my first 30 aneurysms, okay? He saw the work. He saw something. He really encouraged me. He said, listen, you need to take this to the next level. You need to put the data together. You need to get external review, just like we did with the IRB. We get external reviewers. He gave me all the armamentarium I needed to really develop this the right way. So I'm really, he's a mentor to my whole generation, actually. People like him are mentors, okay? So I'm honored that he's here today. But I remember all the people who have advised me in many of my directions, and I'm honored to be with them.
Thank you, Professor. We hope that we can invite you soon to Yemen. Thank you.
I look forward to it.
Congratulations, Salim, for that wonderful lecture. And I can see that the graph of Salim is growing very steeply upwards. And the cases that you showed were amazing and beautiful. And congratulations and best wishes to you, Salim.
Thank you. Thank you, Atul. I'm honored. I'm honored by your words.
Thank you very much. We are already behind schedule, so we have to move to the next speaker. Now we will have Professor Luis Borba from Brazil. Professor Luis, are you with us?
Yes, I'm here.
Are you, Professor?
I have a problem here.
Professor Luis.
Okay.
Education Committee.
Can you hear me?
Yes, we can hear you. Now I will have an announcement. We gave opportunity for one neurosurgeon from Yemen to attend a workshop on the skull-based and scopic approaches in USA. This opportunity will be given to one Yemeni neurosurgeon at the end of the conference. So thank you, Professor Luis, for this opportunity you gave.
Okay. Let's start here. First of all, congratulate for the wonderful meeting. You brought all the men in the world to this conference. It's a great achievement. Congratulations for all of you. I see now that the auditorium is crowded, the people is there, Professor Salim, Abdul Rauf is here, Atul Goel, all these people that were congratulated. Yesterday, many people talk about meningiomas, how to treat, the way to remove, techniques, something like that. I want to share one different ideas, and let's see if it's my fault. One second here, I have a problem here. Oh. I'm not. Just 1 second, okay? Maybe. Oh, quit and reopen. I have to go out and come back, please. Sorry.
Okay, no problem.
Yeah, that's the best thing to do.
Ahmed and John, just want to mention, I had a question while you're waiting for him, how to prevent seizures in awake surgery. In vascular awake surgery, seizures are extremely rare because it's not a cortical surgery. In tumor surgery, it's cortical surgery where you can have seizure. So the risk of seizure in vascular awake is very unlikely. But I'll stop. Thank you.
Can you hear me?
Yes, okay, Louis, onward.
Yes, we can.
Okay, good. Let's start here. Presentation will be about meningiomas. Cure, control, transformation. In the past, it was very easy to decide what to do with meningioma. The great majority of tumors are large. See, intracranial hypertension. You can go there, do a nice surgery, microsurgical removal, and talk about cure. After cancer to come different words. Control. How to control the tumor that is growing so slowly sometimes. How to control the tumor that sometimes is not growing. All of you has one case or more that did the diagnose 4, 5, 6, 7 years later, the tumor the same size. And the patient is living his life perfectly. How if you have a case like this? But today, looks like the people is changing their mind. We need to treat. Harvey Cushing said that is more gratifying in neurosurgery is the radical removal of a meningioma with preservation of neurological function. I want to say this not only for meningioma, but for neurosurgery in general, and for medicine in general. Think first in the patient and after in the tool that you have at home. It's very gratifying. You take a patient like this with a tumor in the craniocervical junction, tetraparesis, come to the OR in the wheelchair, and 1 week later leave the hospital walking. Because you go there and did a microsurgical removal of a benign mass and don't need more treatment. Maybe follow, maybe in the future, maybe you need something. Not is more gratifying than to have a patient like this that came to you, tetraparesis, cannot swallow, facial palsy, diplopia, and have a large tumor like this. If you do the surgery, you go there, microsurgical technique, 10 hours, 12 hours, 14 hours in the OR. But you can do the surgery and remove the lesion and save the life of this young guy. This is our life. It's neurosurgery. See? Today, you see a lot of people talk about time. Oh, this surgery is so long time. Time is not important. As Professor Mefti say, I always say, you give 1 day of your life to save the life of the patient. It's worth. It's our job. And the meningioma is the most important thing. You know that meningioma is very strange. I said in the beginning, very slow. You see this patient here, 10 years follow-up. Nothing changed. Completely, still it's dizziness. See, the patient didn't accept surgery 10 years ago. Now he come back with the same tumor, the same symptoms. This patient maybe different way to think about meningioma. The people ask why to do surgery for large meningioma like this if the follow-up and the growth is very slow. Because you cannot lose the time to treat the patient. You have to lose the time to do the correct treatment. Petroclival meningioma is generally very oligosymptomatic tumor. Diplopia, sometimes ataxia, but when it's large, when you lose this plane here, it's completely different. In this situation, you find a plane. Maybe here, the brainstem will not be there. I show you one case, tell a history about this. A beautiful lady, 35 years old, 2017, came with diplopia and had this large tumor in the petroclival area. See, but still there is a plan. See, the arachnoid plan looks like terrible here, but if you see in T2 here, there is CSF. Maybe you can go there and take it. We proposed the surgery for the lady. She decided, go back home and wait. 19, she came back with ataxia, a little bit worse. See? And diplopia was not a total 6 nerve palsy. And she decided for surgery. But she wanna go back to her home, talk with the family, and this kind, because many doctors told her that she will die. In 20, she came back. Look at that. The surgery that was difficult or time-consuming in 2017, now is almost impossible to get a radical total removal of this mass without severe deficit. We lost the time. You cannot lose the time to remove this tumor. You see, the arachnoid plan that you had 3 years ago, now you don't have anymore. It's very important to have this criteria in your hand. Today we'll talk about approach, anterior, superior, for the nose, for the ear, for the every kind of approach. In petroclival area, is anterior petrosal, posterior petrosal, retrosigmoid, and endonasal. The question is not the approach. The question is what you are thinking, what you are planning to do in this case. You are planning to do a radical removal? You believe that the meningioma has to be removed? You need to correct approach. You believe that the meningioma has to be partially removed and treat with adjuvant therapy? You choose your approach. But you cannot do the approach that I have at home. The only one that I know or I want to learn to do it. See, minimally invasive endonasal approach. Very nice idea. Very nice idea. Look at that, man. Very nice idea. But direct. The patient will love it. But it's for tumor limit like this. Because this 2-6 nerve in the clivus is 8.8 millimeter, no larger than this. And they decide to do the surgery, they didn't get. Do you know why? Was not minimally invasive, was minimally knowledge. For this guy, neurosurgery with ENT and the skull-based center. Now you have skull-based centering everywhere. Huh? The guy does one pituitary, now skull-based center. The guy learned or if the ENT told him, let's come here, but they have no idea how to do it. They didn't train. What's happened? They remove the bone, they create some problem here in the stability here, and the tumor is still there. This is, you need training, you need education. You cannot do surgery what you think that you can do. The limitation of the anterior approach to the clivus is the anatomy that the people that is doing is saying. It's 8.8 millimeters. My former resident, Professor Prevedelo, one of the greatest guys in endoscopic surgery in the world, he published 6. The limitation is the 6th nerve. The distance is 8.8 millimeters. Okay? Maybe it's good for a tumor like this. But the great majority of the petroclival angioma are like this. And in my country, in your country, petroclival angioma is like this. How you can take from the nose? You just bite and go home. The patient will be perfect. But you did the correct treatment? It's not a placebo approach. You go there, bite and see, no complication. No, very fast surgery. The only one that is not happy is the patient. When we realize that the surgery that was made to me was not the correct one. We know today that we have a new game, a new player in the field. Irradiation and radiosurgery. But you know that radiosurgery works. Of course works for some pathologies. Look at that. Cavernous hemangioma. I love to operate. Professor Atul has one of the largest series in the world. But look at what happens to gamma knife. Disappear. The lesion disappear. Look at what happens to trigeminal schwannoma. See? It's not the best way to treat. I believe that trigeminal schwannoma should be operated, but you see some things working here. And look, the meningioma. Nothing's happening. It's not changing. But they say that's control. It's control. Control. I have a patient with 10 years follow-up is control with no treatment. Maybe it's different. We know that radiation therapy for meningioma works, but maybe control some time, but the tumor will come back in 9, 10 years, and sometimes come transforming a benign lesion in more aggressive. You have a case like this, they show this, oh, it's very nice, did surgery and radiosurgery here, remain surgery here. Is a little bit small, 7, 10 years later, come back again. We know that radiation therapy precludes the neo-formation of vessels, neovascular formation. This is a case, while I show this here, this patient has a large tumor here, was operated, was irradiated, and after the tumor came back, and you have this. They say that is not radiation effect. They say that is venous conjection, but it's radiation effect. And we look the pattern of vascularization. There is no new vascularization. The sinus is occluded, but there is no real new vascularization. Completely different that this situation here, that the patient was operated, see, long time ago, now there is a recurrence, the sagittal sinus is occluded, but a new vascular transformation. without radiation therapy. I think that the radiation therapy had a hole in this situation. Here, not showing new vascularization, correct? Here, giving, see, allowing the new pathway to vessels. In the most interesting, that you go to the WNS, the most important, they say the largest meeting in the world, in America. See, you go to the booth of Gamma Knife. In Gamma Knife, you see like that, Lexel gamma plane. Look, the tumor, that is the example for Gamma Knife treatment. Man, look at that. Look this attachment here. Very small attachment in the tentorium. It's a very straightforward surgery that you can do in everywhere. You just go there, very similar case, see, supracerebellar approach, see, not a paramedian, okay? Cerebellum down, I don't know the position, you can discuss the position, but I want to say this. You just come here, cut the vascularization, cut the attachment, cut the tentorium that is there. You can separate totally. You can see that ball that was until there. You go, continue the surgery, and just resect this mass. Can be in piecemeal, can be the total mass, but the cerebellum is coming down, the gravity is coming down, and the tumor is coming almost alone, because the vascularization was totally cut when you cut the attachment. See? And the big ball that the guy from Gamma Knife, Lexel Gamma Knife, indicated radial surgery, now is cured without necessity of radiation therapy. Just understanding the tumor, just understanding the anatomy and the tumors come. The tentorial meningioma, prep and retro approach. We know that also radiation can induce meningioma is very rare. It's not common, but may happen. You remember after the Second War, many Jewish that went from Europe to Israel had tinea captis, and they treat a very, very, very low doses of radiation therapy and develop a radiation-induced meningioma, one of the worst meningioma. And now the people is doing like this. Very interesting. I don't show the names, but very interesting. Radiation-induced meningioma. You remove, of course, if you remain a tumor, if the tumor regress, we need to treat with radiation. Radiation-induced meningioma, you remove. If you remain a small piece, we need to give radiation. It's okay. But look, the paper, what the example that they give to treat radiation, for radiation. Man, look at that. This you can take 10 centimeters margin here. See, it's crazy. The people, what they are thinking. If you want to show example, show a very large meningioma that you cannot remove. You see, but not show this, my friend. Don't show this. Do you know why they want to show this? Because the great majority of the meningioma today with the MRI are this size, very small. And the great majority of the patients are asymptomatic, completely asymptomatic. See? It's put full on the fire. It's good. You need to learn. Radiosurgery and radiation therapy is a very good tool. but use the way that you need. Use the knife the way that you need. Use the gamma knife the way that you need. But sometimes you don't need knife. You don't need gamma knife. You don't need the real knife. This is a paper from France, cavernosinus meningioma, that some people today say that they remove everything. Look at the results. 19% increase in size. 71% is stable. 90.4% decrease. Very similar to the treatment of radiation. Very similar. What is the problem here? 78% regress the symptom just with corticoids. Or 80% the patient had just diplopia, okay? In 90%, almost 10 years, no more diplopia, and the tumor was there. Talk about cavernosinus. That the people now say that can remove everything. Of course, have complications, have patient have the five cases that fail the conservative treatment, 4 unchanged, 1 decrease. Very interesting. But in the follow-up, radiation-induced meningioma. Die. It's malignant. It's aggressive. See? It's terrible result. Natural history. Wait and see. If you do a primary treatment with radiation therapy, you have 80 control. If you do radiation therapy after the tumor starts to grow again, it's completely different. 45%. It's just observation, 70%. It means that if you do surgery, if there is a small tumor there, wait and see. If you see a very small meningioma located in one critical area, wait and see. If you have a meningioma in a patient with some age, wait and see. Take a coffee and wait. Look, this lady here, 66 years old, just headache, no neurological deficit. See? What this patient needs? Run away from neurosurgery, run away from radiosurgery, and just see the ophthalmologist to see if the optic nerve is okay. If the optic nerve start to have problem, if she start to lose the vision, we need to do one surgery that is very conservative. You come here, extradural, remove the anterior clinoid and liberate the optic nerve and falciform ligament and liberate the nerve. You see, you improve the vision. If you come here like crazy to remove all the tumor in the cavernosinus, will be ophthalmoplegic, or at least to have deficit in the post-op. Example like this, a large tumor like this invade the posterior part of the cavernosinus. We do the surgery. This part was in the sphenoid sinus. Here's V2, here's V3, here's the superior orbital fissure. See? There is tumor still in the superior orbital fissure. Here's the carotid artery, the vein, the nerve. In the post-op, we leave a small piece of tumor in the superior orbital fissure and follow. Maybe need radiation, maybe not. Wait and see. But preservation of the oculomotor function. It's very important, this situation. In conclusion, I want to say that treat the patient, not the image. We know that the only curative treatment for meningioma of skull base is the radical surgical removal. But when it is possible, the trophy is not the tumor. The trophy is the patient. Today, you need to study meningioma, the hormonal, the molecular, the crucial. It's important to make the decision. See, if you have any doubt what treatment to do, the best way is wait and see. And the time you give the direction, the best way to treat this patient. And I take you all the opportunity. I think skull base is commitment, is focus, and especially judgment. As our doctor, you need judgment. Thank you very much. Sorry for the long time. Thank you.
Thank you very much, Professor. Very interesting lecture. We enjoyed everything. Anyone have any question for Professor Lewis? Thank you, Professor. It's an honor for us to have you today with us. And thank you again for the opportunity you gave for one Yemeni neurosurgeon to attend this workshop.
Thank you. I appreciate it. Thank you. Bye-bye.
Professor.
Atul, thank you. Bye-bye. Ciao.
Bye-bye, Professor. Thank you very much.
Bye-bye.
Thank you, Dr. Goel. Thank you very much. Thank you, John. And
Thank you.
by this, we conclude.
Ciao,
the
ciao.
Ciao, ciao. Ciao, Vladimir. Un abraço.
Thank you very much.
Professor Schroeder.
Hi.
Thank
I'm in Kuwait.
you. Thank
Yeah.
you.
Are you in Kuwait now?
No, not yet.
Good. Going next week.
Yes.
Okay.
Bye-bye.
Bye-bye. See you. Ciao. John, let's talk later.
Thank you.
Thank you. Bye-bye. Thanks.
Thank you, everyone. And thank you, Ahmed, for putting all this together. You did very good work, Ahmed. Great. The Yemen neurosurgery community owes you a lot, Ahmed. Thank you.
Thank you very much.
Bye-bye. Thanks. Bye-bye.
We are honored to have you all with us. Thank you. Okay. So by this, we conclude the second day of the 4th Yemeni Neurosurgical Conference. And see you tomorrow, inshallah. Okay, John, tomorrow we will have from 8:30 until 1 p.m. only.
Okay.
Okay, goodbye.
Thanks, everybody. We're off the air. You can hang around and network if you want.